مساء الخير جميعا. My name is Dr. Nasser Al-Jahani, consultant endocrinologist from East Jeddah Hospital in Jeddah. First of all, I want to thank Saudi Heart Association and to thank Boehringer Ingelheim for their kind invitation. Also, I want to thank all attendees this afternoon event. So today, really, we have comprehensive program for almost 4 hours. The first part of the program will start with type 2 diabetes as cardio-renal metabolic complex disease. It will be presented by Dr. Raed Al-Dash. He is the head of Endocrine Division and Diabetes Center, Department of Medicine, King Abdulaziz Medical National Guard, Riyadh. He is Assistant Clinical Professor in King Saud bin Abdulaziz for Health Science University. The second speaker today will be evolving evidence-based clinical recommendation in type 2 diabetes by Dr. Ibtisam Baisa, Associate Professor of Medicine, Imam Abdul Rahman bin Faisal University, Consultant Internist and Endocrinologist, Dammam Medical Complex. The third presentation today is Emperor reduced a late-breaking trial in cardiovascular and renal outcome with empagliflozin and heart failure with Dr. Kamal Al-Ghalayini or Prof. Kamal Al-Ghalayini. He is consultant cardiologist and heart failure specialist from King Abdulaziz University in Jeddah. The fourth presentation today at 3 o'clock is potential role of selective glucose transporter inhibitors in chronic kidney disease by my monitor, Prof. Abdul Rauf Mahfoud. He is consultant endocrinologist and the head of the endocrine section in King Faisal Specialist Hospital and Research Center in Riyadh. The fifth speaker today is Abdul Wahab Bawahab, is my colleague, is consultant endocrinologist, Saudi Germany Hospital, head of endocrine section, Saudi German Hospital in Jeddah. He will talk about practical guidance in selective glucose transporter 2 inhibitors proper use. The other 2 speakers is Dr. Rashid Al-Juwair. He is consultant endocrinologist and head of endocrine and diabetes unit in KFMMC in Eastern Province. The second case presentation by Dr. Sayyid Gadir. He is consultant physician and endocrinologist at Al Habib Medical Group, Al Ulayya Hospital, Riyadh. He is a fellow of Royal College of Physicians from UK. So today we'll start with Dr. Raed Al-Dash, who will give us a talk as type 2 diabetes as cardiovascular renal metabolic disease. Are you ready, Dr. Raed? You hear me, Dr. Raed?
Yes, Dr. Nasser.
Yeah, can start, please, Dr. Raed?
Yes, sure.
You can share screen, please.
Okay.
Yes, excellent.
Clear now?
Yes, I can see.
Okay. So, good afternoon, everybody. In this Friday, I want to thank Dr. Nasser for nice introduction. I want to thank all of my colleagues that attending with us today in this workshop. And also I want to thank all the attendees in this special day and the weekend that attending with us today. I want to thank all, the hidden soldier, actually, Dr. Saber, and all other colleagues in Boehringer to arranging this lectures. So today we will talk about type 2 diabetes as cardio-renal metabolic complex disease. As you know, this is a new era, and there is a lot of evidence came, and a lot of guidelines even changes after this evidence came. So we will start with introduction, then we will see how much the change in outcome of cardio-renal metabolic condition. Then after that, we will go for cardio-renal metabolic condition in guidelines for patients with type 2 diabetes. As you know, the heart and renal and other metabolic organ, they are connected to each other. And the heart, as you know, it's most metabolic demand organ, susceptible to change in volume and metabolism. The kidney, playing a role in glucose and volume homeostasis and blood pressure regulation. So the regulation of energy metabolism by liver, pancreas, and fat is essential for health functioning for organs, especially for heart and for kidneys. And I remember in this, special day, the Friday, the Prophet Muhammad sallallahu alaihi wasallam, he said that if one organ, if your body affected, the other organ, it will be affected. They are related to each other. So I remember this talk, Prophet Muhammad, in this special day. Allahumma salli alayhi. So the cardiorenal metabolism system are interrelated to each other. So the acute or chronic dysfunctioning in one, for example, in heart or kidney, it will affect the others. Each dysfunction organ have ability to initiate and to affect other organs through hemodynamics, neurohormonal, immunological, or biochemical feedback pathway. And as you know, the type 2 diabetes is a risk factor for disease-related cardiac and renal disease, renal systems, so affecting whole body. So as you know, the risk factor to affecting the organs, either diabetes, hypertension, obesity, or dyslipidemia. So it will start with endothelial dysfunction. Then after that, it will start with endothelial dysfunctioning, then atherosclerosis, microalbuminuria, coronary artery disease, macroalbuminuria, MI or stroke, chronic kidney disease, left ventricular remodeling, heart failure, end-stage renal disease, and cardiovascular death. So as you know, the metabolic dysfunctioning, it's add to cardiac and renal burden. So it will start with affecting kidneys and renal and others. As you know, the hyperglycemia, dyslipidemia, increase insulin resistant, and change in hormonal by itself, and increasing adipokines, it will affect the heart and kidney. It will affect the heart, like causing heart failure, vascular dysfunction, atherosclerosis, and will affect the kidney, like fluid retention, albuminuria, and decreased kidney functioning. Also, cardiac system or cardiac abnormalities, it will affect also the renal and metabolic disease, and will affect the other organ. For example, as you know, the neurohormonal activity, hypoperfusion, volume overload, increased arterial resistance, change in autonomic dysfunctioning, it will affect the kidney through increasing hypertension, albuminuria, and decline in kidney functioning. It will affect also the metabolic system, like increasing insulin resistant, increasing the free fatty acid, and dyslipidemia. What about the renal functioning? The renal functioning or the renal system, if it's affected or having abnormality, also again, it will affect the heart and metabolic. So in the renal, activation of renin-angiotensin-aldosterone system and sympathetic nervous system, it will cause sodium and fluid retention, hypertension, arterial calcification, and oxidative stress. So this will affect the metabolic, and affecting the heart, they will affect the metabolic system through increasing insulin resistant and abnormal glucose levels, and it will affect the heart through ventricular hypertrophy, heart failure, vascular dysfunction, and atherosclerosis. So now the diabetes, as you know, 50% of those patients with type 2 diabetes, they having fatty liver disease. And over half of the patient with type 2 diabetes reported to be obese. And type 2 diabetes, as you know, by itself, it would reduce the expectancy of life by 6 years. So it will be decreasing the half-life of the life expectation for the patient. And as you know, the type 2 diabetes also reducing life expectancy in patients with cardiorenal abnormality. So there is overlap between the disease. So the patient did not come only with type 2 diabetes, it will come with heart disease and chronic kidney disease. And as you know, 1 out of 3 of the patient having type 2 diabetes, they will have cardiovascular disease. And there is 2 to 5-fold increasing in hospitalization for heart failure in patients with type 2 diabetes. As you know, the cardiovascular disease is the leading cause of mortality in patients with type 2 diabetes. and there is up to 67% of patients with heart failure, they are estimated to having chronic kidney disease. So the risk of death increasing as a kidney functioning decline, and the presence of chronic kidney disease in patients with heart failure increased risk of mortality. And as you know, if you're having one organ failure, there is risk of mortality. If you have two organ failure, there is again increased risk of mortality. If you have three organ failure, the risk of mortality, it will be increased more and more. The chronic kidney disease is affecting about 40% of patients with type 2 diabetes. And diabetes and hypertension is the cause of more than 80% of end-stage kidney disease worldwide. Life expectancy is reduced in patients with type 2 diabetes and early chronic kidney disease by 16 years. And there is 10 more of than chronic kidney disease. So as I said, if you have two organ failures, it will be the risk of mortality, it will be increased. So now what about the changing of outcome of cardiorenal metabolism condition? As you know, all the guidelines try to show us how we control the risk factor of cardiovascular death. So they will start with glucose controlling. So they try to target the hemoglobin A1C less than 7. And we have a lot of options and a lot of treatment and a lot of diabetes medication to control this, like Metformin, SGLT2 inhibitor, GLP-1, DDB4, sulfonylurea, TZDs, insulins, and others. And also the blood pressure, they said, if the patient is high risk, you should control the blood pressure that should be less than 130/80s. And if it's very high risk, so if it's lower risk, we should decrease it to 140 less and or 140/90s. So usually the medication we have or the treatment, either ACE or ARBs, like RICE blockers or calcium channel blocker, thiazide inhibitors. If the blood pressure is high, more than 160, sometimes we starting with dual therapy as a first line of treatment. Even in diabetes, we have the same. Regarding LDL, if the LDL should be less than 1.7 if the patient having high risk, or we should decrease the LDL more than 50%. If the LDL less than 2.6 if at moderate risk, so we have a lot of options, a lot of treatments. We having statin, we having ezetimibe, we having PCSK9 inhibitors. Regarding individual diet and lifestyle, the target is weight loss and smoking cessations. So the treatment is very controlling the diet, physical activity, and behavioral therapy. So as you know, the type 2 SGLT2 inhibitors and GLP-1, they providing a lot of effect. So in multiple systems. So for example, in SGLT2 inhibitors, they will reduce the MACE, cardiovascular death, hospitalization for heart failure, and also they having good outcome in hard kidneys and albuminuria, and if the patient having GFR worsening. Again, the GLP-1 having reducing in the MACE, cardiovascular death, and albuminuria. I will show you all the studies talking about this. Also statins and ACE inhibitors and ARBs, they having cardiorenal benefit, and they reducing albuminuria and cardiovascular benefits. So we having a lot of, randomized control trial, as you know, ACCORD, ADVANCE, UKBDS, FEDIT. They talking about estimating the effect of extremely controlling the risk factor and more intensive glycemic control and all risk factors, what will happen for mortality and macrovascular complications. Actually, the data came to be that there is no significant effect if we are controlling, rapidly controlling all the aspects in randomized control trial as a macrovascular complication in the long term. Even some of them, they talking about increased risk of mortality. Now, what about SGLT2 inhibitors and GLP-1 agonists regarding the MACE reduction with patients with type 2 diabetes? As you know, we having a lot of medications in SGLT2 inhibitors and GLP-1 talking about MACE decreasing, and it was very significant in empagliflozin and in liraglutide in the LEADER study and empiric outcomes. The cardiovascular death, it's also showing there is only empagliflozin having the decreasing risk of cardiovascular death in patients with type 2 diabetes, and it was very significant in these studies. In hospitalization for heart failure, the SGLT2 inhibitors showing significant decrease in hospitalization for heart failure in empagliflozin, canagliflozin, dapagliflozins. There is special, special trials doing for heart failures like DAPA-HF, and there is also secondary outcome from the DECLARE TIMI 58 and CANVAS program and empiric program. Now, if we try to make the summary for all classes of be using a class of diabetes and hypertension and statin using for treatment of type 2 diabetes, if we try to see SGLT2 inhibitors, they are decreasing MACE. The empagliflozin, they are decreasing cardiovascular death. Hospitalization for heart failure also, heart kidney outcome is decreased, albuminuria is decreased. All cause of mortality only empagliflozin. If we try to see GLP-1 agonist, the MACE is decreased, the cardiovascular death only in liraglutide. Hospitalization for heart failure and heart kidney outcome is neutral. Albuminuria is decreased, all cause of mortality with liraglutide. ACE inhibitor, it decreased MACE for sure, it decreased cardiovascular death, it decreased hospitalization for heart failures. There is no outcome in heart kidney outcome, it decreased albuminuria and all cause of mortality. ARBs no change in MACE, but it decreased cardiovascular death, decreased hospitalization for heart failure, decreased heart kidney outcomes, decreased albuminuria and all cause of mortalities. The statin decreasing MACE, decreasing cardiovascular death. There is no change in heart failure and kidney outcome, but it will decrease the albuminuria and all cause of death. The effect of SGLT2 inhibitors, there are many effects in many organs, either immediate effect or downstream observing effect. So SGLT2 inhibitors, as you know, it's diuretic, it's glucose excretion and natriuresis. So they having decreasing myocardial sodium content due to inhibit of sodium and exchanging receptors, and it having decreasing intraglomerular pressure, decreasing left ventricular wall stress and mass, and decreasing inflammatory and oxidative stress. It will also decreasing afterload, and it's decreasing also preload, and it will increase hematocrit. So they will having downstream observing effect. They decreasing cardiovascular event. They will decrease kidney disease, decreasing blood pressure, decreasing weight, and decreasing in hemoglobin A1C. Now, what about the guidelines? Is the guidelines changing, or the guidelines same it's not change? Actually, there is many approaching and many guidelines. They talking like ASD guidelines, ADE guidelines, ASC guidelines, and American College of Cardiologies, and a lot of ASD. They talking about, those kind of medications that we have, and they try to change that algorithm to be used after metformin, and a lot of them they try to put the SGLT2 inhibitors and GLP-1 after metformin. And for example, in ACE guidelines, they said after metformin, they said if you having chronic kidney disease or heart failure using SGLT2 inhibitors, and if you having atherosclerosis, cardiovascular disease, or at risk of atherosclerosis, cardiovascular disease, start with liraglutide as a GLP-1. And some of the European guidelines nowadays, they try to be moved step on. They said, if your patient having atherosclerosis, cardiovascular disease, you can start with liraglutide as a first option before metformin. And if you're having heart failure or hospitalization for heart failure, try to use SGLT2 inhibitors. And there is some of the guidelines, they said in non-diabetic patient, even you can start with SGLT2 inhibitor as heart failure medications. So the guidelines start to be changed since 2015 till now about which kind of medication to be recommended. For example, in 2020, they recommend GLP-1 and SGLT2 inhibitor with proven cardiovascular benefit if they having atherosclerosis predominant. And they talking about SGLT2 inhibitor with evidence of reducing heart failures and chronic kidney disease if HF or chronic kidney disease is predominant. And nowadays there is a lot of, a lot of studies talking about heart failures in SGLT2 inhibitors. Some of them is published and some of them going to be published. For example, we having DABA CKD, we having Credence, and we having Imperial Reduce and Imperial Preserved. And we will have a lot of, publications to be, studies to be ongoing, like, for example, in 2022, there be scored about sutagliflozin and EMBA kidney, and they will be flow for semaglutide. So a lot of, a lot of studies going to be published, maybe this year and some of them next year. We are almost in 2021. So there is a lot of publication to be talking about these kind of medication and other medication, their effect on kidneys. So if we try to summarize what we mentioned today, that cardiorenal metabolic system is interrelated, and dysfunctioning in one organ and one system can induce or contribute to dysfunctioning in others. That's why I mentioned the Prophet Muhammad hadith. They said if you're affecting one of your organ, this is maybe 1,400 years back. They said if one of your body's organ in your body is affected, the other will be affected. Other thing, that type 2 diabetes, cardiovascular disease, heart failure, and chronic kidney disease, they are interrelated to each other. And the presence of type 2 diabetes associated with cardiac and renal progression. So they start with type 2 diabetes, then we start with kidney or heart, then the other organ try to affect the others. The approach in type 2 diabetes care is necessarily to address cardiovascular and renal and metabolic aspect of the disease. So if you try to choose for antihypertensive medication, try to use the most appropriate one. If you try to use lipid medication, try to use the appropriate one. If you try to use the diabetes medication, try to use appropriate one to prevent the cardiovascular and kidney outcome by all the tools you have, and try to assess your patient which one of them is better and which one is less benefits. The guidelines and society recommending to using agent with cardiorenal metabolic benefits such as SGLT2 inhibitors and GLP-1 agonists for treatment with type 2 diabetes. Also, they try to also prove that ACE and ARBs is first line therapy if the patient having albuminuria or patient having at risk of albuminuria or macroalbuminuria, to using these kind of medications. Also to address if the patient having LDL target for type 2 diabetes, to start to use statin as soon as possible. I want to thank you so much. I want to thank Mr. Chairman and all of our colleagues arranging this. And at the end, I want to remind myself and remind you that the coronavirus is not end yet. And still, there is second wave in a lot of countries, and there is the diseases try to be transfer or try to be moved to another generations. So I would recommend myself and you guys to take the vaccine. I'm not the right one to recommend to take the vaccine, but those with high risk, like elderly, type 2 diabetes, I recommend them to take the vaccine. Also, I remind myself and you guys, please wear a mask, do social distance, try to wash your hand, and thank you so much.
Thank you, Dr. Raed, for this excellent presentation. And even finishing before the time, the topic of Dr. Raed was type 2 diabetes as a cardiorenal metabolic complex disease. Now we'll go to the second speakers. The second speaker is Dr. Ibtisam Baisas. He is Associate Professor of Medicine, Imam Abdurrahman bin Faisal University. She is consultant, internist, and endocrinologist. at Dammam Medical Complex. She will talk about the evidence-based clinical recommendation, the latest recommendation in type 2 diabetes. The floor is yours, Dr. Ibtisam.
Rahim. Thank you, Mr. Chairman, dear guests and colleagues. I would like to welcome you all today and thank Boehringer for sponsoring this event. And I would like also to thank Dr. Raed because he made my life easy, and I'm going to repeat some of what he has mentioned. This is my slide for disclosure, and this is my objective. After a brief introduction, we'll talk about the new therapeutic era in type 2 diabetes management, and I will summarize and give you the result of the cardiovascular renal outcome trials that have impacted and changed the guidelines, and then we conclude. As we have heard, type 2 diabetes is a progressive disease with complex and multifactorial pathophysiology, and type 2 diabetes is a strong and increasingly prevalent independent risk factor for cardiovascular disease morbidity, renal disease, and mortality worldwide. And we know that up to 50% of unselected patients in the cardiovascular clinical cohort have concomitant diabetes. We know that the risk of myocardial infarction and cardiovascular disease in people with diabetes is increased in both men and women, and that takes place at earlier age. And women also, they lose their normal female protective cardiovascular effect early on. As we have heard, also people with type 2 diabetes has an increased risk for heart failure, and maybe up to 50% of patients with type 2 diabetes may develop heart failure. We know that diabetes is the #1 cause for renal failure, and we know up to 50% or more of patients with end-stage renal disease or on dialysis are diabetic. So we have no doubt that better prevention of complication with tighter control, the earlier is the better. And this is what we call the legacy effect or metabolic memory that was proven by DDCCT trial in type 1 diabetes and the UK BDS trial in people with type 2 diabetes. We also know the link between the control and the microvascular and myocardial infarction risk. The lower the A1C is, the lower the risk for microvascular disease and myocardial infarction. And also we learned from the UK BDS trial that even 1% reduction of A1C will result in significant reduction of myocardial infarction and microvascular complication. So we have a clear association and consistency observed between worsening glycemic control and worsening risk. And we know without any doubt that intensive glucose control decreases that risk. And actually this was true until 2008 when we had the ACCORD trial, which this trial has been terminated earlier because you notice that intensive control resulted in increased mortality and death. And that at that time, there was a question whether this is true, and this is against what has learned before that, and was the result is really linked to the patient criteria that has been included in the study, people who are elderly included in the study with long-standing diabetes, hypoglycemia, established comorbidity, complex treatment that may have affected that result, or whether there is a specific drugs or treatment diabetes therapies that results in cardiotoxicity or cardioprotection. And actually from that date, we had the birth of the cardiovascular outcome trial in type 2 diabetes. Since that trial in 2008, FDA have recommended that any diabetes drug, before it is approved, it should be tested in people with high risk, elderly populations, women, renal impairment, people with cardiovascular disease before the drug gets approved. In the same time, we had also evolution in the diabetes therapy. We had a growth of newer classes of treatment for type 2 diabetes. And also we learned more about the pathophysiology of diabetes. This is the differenzo omnius octet, understanding the causes of hyperglycemia is not only one, is the pancreas, but multifactorial. And with that, we had developed more classes of drug that can target those different pathology. So in view of the FDA recommendations and the understanding of the pathophysiology and also the development and evolution of treatment for type 2 diabetes, we have seen really a growth in the cardiovascular outcome trials. Some of them is already published and some of them is still in the pipeline. And all those cardiovascular outcome have been run to prove cardiovascular safety, but to some of our surprise, some of those drugs have shown even cardiovascular and renal benefit. And those results have definitely impacted on the cardiovascular outcome trial, have impacted on the guidelines and the management of type 2 diabetes. We know guidelines are important for both practitioner and patient to decide about the management plan, but we know still applying guidelines still needs individualization and require judgment, even if those recommendations are linked to evidence, because we know that one size does not fit all. And this is the component of the glycemic control, whether you follow the IDF or ADA or ACE. In the past, this applied to all patients with type 2 diabetes. However, in 2012, up to date, we have learned that this is not suitable for everyone, and it has to be centered to more stringent or less stringent based on the patient background and life expectancy and comorbidity. You should select your target A1C and choose your treatment based on this. Even in 2018, up to date, we had even more focused and centered approach and focusing on the comorbidities like atherosclerotic cardiovascular disease, kidney disease, and heart failure. So the decision for treatment before October 2018, we were focusing only on glycemic target. What is the target decline of A1C, whether we want to target fasting, postprandial, or both, and what is the A1C. So our focus were only glucose center with no preference to any drug. However, after October 2018, we had more centered approach focusing on many more other than the glucose and the A1C. We have focused on the mainly cardiovascular, renal safety, hypoglycemia, weight gain, and cost. So we have more specific drug preference, and this is based on the cardiovascular and renal outcome trials. So before we discuss those guidelines, we have to mention some of the evidence that Dr. Raed have already mentioned. And because of the time, I'm just going to give you a summary of the results of those guidelines and recommendations. And I'm going to refer to MACE in my talk. For those, just to remind you, MACE means Major Adverse Cardiovascular Events, which is defined as composite of non-fatal stroke, MI, and cardiovascular death. I'll start with metformin. Actually, metformin is the old gold treatment for type 2 diabetes, not only for its efficacy in reducing hemoglobin A1C, but it has many more additional benefits, including anti-cancer as well as cardioprotection. And actually, metformin in the UK BDS trial have proven to reduce relative risk of myocardial infarction or cause mortality significantly. So metformin has a cardioprotective effect. And as you can see in most of the guidelines, the ACE and the ADA, metformin can be used as monotherapy, dual therapy, or triple therapy all through the treatment. And what comes after metformin depends on really many factors. And now the focus is in comorbidity as well as subsequently to the weight and risk to hypoglycemia and degree of hyperglycemia. So what comes after metformin? I'll start with sulfonylurea, which is really, we have experience with this drug for many years. It's really effective, cheap. However, there was some concern about hypoglycemia and cardiovascular risk with sulfonylureas. Sulfonylureas has been known to interfere with the adaptive ischemic preconditioning and increase the myocardial infarction signs. Is this true for all sulfonylureas? The answer is no. And the reason is for the following. Different sulfonylurea have different binding to sulfonylurea receptors. And as you can see here, the gliclazide and glimepiride has selective binding to sulfonylurea receptor 1, while older generation sulfonylurea, they don't have selective binding, and that will affect the ischemic preconditioning. Also, the different risk for hypoglycemia, and this is because of the reversibility of binding to the, again, sulfonylurea receptor. As you can see here, glipizide and glimepiride have irreversible binding to sulfonylurea receptors, while gliclazide, MR have reversible binding to sulfonylurea receptor, and that's why gliclazide MR had lower risk for hypoglycemia. Also, we learned in the UK BDS trial, people in the intensive group, they were on sulfonylurea and insulin, and those people on sulfonylurea were on chlorbromamide and gliclazide. Yet, we were able to achieve glycemic target and prevent complication with those drugs with no increased risk of cardiovascular complications. However, subsequently, we had more study to compare the newer generation sulfonylurea to those with the older generation sulfonylurea, and all studies consistently showed that the newer generation sulfonylurea, like gliclazide and glimepiride, had lower risk for cardiovascular events and myocardial infarction as compared to the older generation glipglamide. And this is again related to the sulfonylurea receptor binding, as I mentioned. TZDs, bioglitazone, again, this is a good drug, powerful drug, good for insulin resistance. However, there were concerns about weight gain and heart failure risk. And in 2004, we had the PROACTIVE study that in this study, it showed that bioglitazone had cardiovascular benefit and stroke benefit with 16% reduction of MACE and significant reduction of stroke by 47% and myocardial infarction 28% and atherosclerotic cardiovascular syndrome by 37%. However, in this study, it has been shown that the risk for heart failure is increased with bioglitazone. DDP4 inhibitor, again, this is a good class of drug that act on the DDP4 enzyme to inhibit the conversion of the active GLP-1 and GIP into an inactive form, and hence increase the release of insulin and control the blood glucose. This is not head-to-head comparison. However, as you can see here, DDP4 inhibitor class may result in A1C reduction of up to 0.8%. Again, this drug is weight neutral, and some of those drugs in this class may result even in weight reduction of up to 1.5 kilogram. However, when you add this drug to other classes like sulfonylurea and insulin, you may abolish that effect and result in weight gain. As you can see here, compared to sulfonylurea, DDP4 inhibitor has lower risk of hypoglycemia as compared to sulfonylurea, makes this drug is a good option for people at risk of hypoglycemia and particularly the elderly. Again, this is a meta-analysis of cardiovascular event, not head-to-head comparison, but as you can see, most of the drug in this class had no increased risk for cardiovascular event. So it's cardiovascular safe. And in more details, in the Sevortemi, Examine, and TICOS trial, they looked at the saxagliptin, allogliptin, and sitagliptin, and they all have shown that there is no increased risk of cardiovascular disease. However, there is also no benefit, cardiovascular benefit of those drugs. When it comes to heart failure, as you can see here, most of the drugs in this class have no increased risk for heart failure, except for saxagliptin, which in the Sevortemi study have showed increased risk for heart failure. We have more recent study in this class of drug with linagliptin. We have the Carmelina Trial and Carolina. In the Carmelina Trial, they looked at the long-term cardiovascular and kidney safety with DDP4 inhibitor linagliptin, and they found that this drug did not increase cardiovascular risk, no increased heart failure, no cardiovascular benefit. However, it proved to be also renal outcome and has renal safety. In the Carolina trial, evaluating cardiovascular safety, but the comparator here is glimepiride, sulfonylurea glimepiride. Again, they have shown similar results with lower risk of hypoglycemia and weight gain in favor of linagliptin. And this study actually have an indirect evidence that glimepiride is also proved to be safe from the cardiovascular point of view. So this slide summarizing the DDP4 inhibitor cardiovascular outcome trial, as you can see, most of the drugs are really safe. Cardiovascular outcome trial are safe, and also in terms of heart failure, except for saxagliptin, which increases the risk for heart failure. GLP-1 agonists, this class act by reducing appetite centrally and also reduce or delay gastric emptying. And we have the short-acting GLP-1 analogs that is taken twice daily, the long-acting once daily, and the prolonged-acting, which is taken once weekly. This class of drug results in 1.9% reduction of A1C. Also, it may result in up to 4 kilogram weight reduction. And also in the SUSTAIN trial, they found that semaglutide even resulted in more weight reduction of up to 6 kilogram. Hypoglycemia risk is again very low. However, if you add it to drugs like sulfonylurea or insulin, that may increase the risk for hypoglycemia. This class of drug has an additional benefit of reducing systolic blood pressure of around 3.5 millimeter mercury. And when we look to the cardiovascular outcome trial, the first trial is the LEADER trial with liraglutide. In this study, liraglutide have proven cardiovascular benefit with 13% reduction of MACE and also mortality benefit with reducing the death from cardiovascular disease by 22%. When it comes to heart failure, there is a safety profile, no increased risk for heart failure, hospitalization for heart failure. Similarly, in the ELIXA trial, lixisenatide have been tested for MACE, but showed no increased risk for heart failure or cardiovascular disease and no benefit with lixisenatide. In the SUSTAIN 6 trial, semaglutide again showed cardiovascular benefit with 26% reduction in MACE, stroke benefit with 39% reduction in stroke. However, it was not shown to affect or reduce the mortality benefit. In the XSL trial with exenatide, again, exenatide have been shown not to increase the cardiovascular risk, not heart failure with no cardiovascular benefit. In the REWIND trial with dulaglutide, this is again a very important study because in this study, this is one of the first studies to have most of the people included, 2/3 of the people included in this study, they don't have established cardiovascular disease, but people at risk for cardiovascular disease, as compared to all previous studies where the majority of the people in this study were people with established cardiovascular disease. So this is one of the first studies that looked at this primary outcome, and they found there is cardiovascular benefit with 12% reduction in the MACE result, and this is for people even at risk. So this is one of the first trial that have shown that benefit of dulaglutide or this class, even in those with cardiovascular, at risk of cardiovascular disease. Harmony outcome with albiglutide showed again 22% benefit of MACE reduction. And when we come to the renal outcome trial, the leader trial with liraglutide showed again renal benefit with reduction of the new onset persistent macroalbuminuria in people with diabetes and kidney disease. SUSTAIN 6, again, semaglutide showed the reduction of the new or worsening nephropathy and new onset of macroalbuminuria. And the REWIND trial, again, in people with diabetes and kidney disease, they showed that dulaglutide resulted in renal benefit with reduction of first macroalbuminuria and renal composite with decline of eGFR. So to summarize, GLP-1 agonist cardiovascular outcome trial, liraglutide, semaglutide, dulaglutide, and albiglutide all had positive cardiovascular benefit. And this is the hierarchy with the preference to liraglutide based on the additional mortality benefit that has been shown in the leader study, which was not shown with the other drugs in this class. And the outcome, renal outcome trial, liraglutide, semaglutide, dulaglutide, all have shown positive, favorable outcome in terms of renal benefit. And this is related to the lower rate of new onset of persistent macroalbuminuria. Now we come to this class of drug is the SGLT2 co-transporter inhibitor. And this class of drug act on the SGLT2 co-transporter to inhibit the reabsorption of glucose to the circulation. And actually, this class of drug results in almost around 1% reduction of A1C, 40 milligram reduction of fasting blood glucose, and it results in up to 3.4 kilogram weight reduction. Again, these are not head-to-head trials. Also, in addition to that, may result in a systolic blood pressure reduction of around 5 millimeter mercury. Because of the mechanism of action of this drug, you can see the risk for hypoglycemia is extremely rare, and the risk increases if you add this drug to insulin or oral hypoglycemic agents. When we come to the cardiovascular outcome, the first trial in this class was the EMBARIC trial with empagliflozin, which showed that empagliflozin resulted in cardiovascular benefit with 14% reduction in MACE. And you can see the line converts very early, so the benefit takes place very early in the course of treatment. It resulted also in mortality benefit with cardiovascular death reduction of 38%, mortality reduction of 32%, and heart failure benefit with reduction of heart failure hospitalization by 35%. Similarly, with the CANVAS trial, canagliflozin have been shown also to reduce, have cardiovascular benefit with 14% reduction of MACE and also 33% reduction of heart failure. However, in this study, canagliflozin did not show to be associated with mortality benefit. We declared TEMI with dapagliflozin. This study have shown that dapagliflozin resulted in significant reduction of heart failure benefit, and also hospitalization, 27% reduction of hospitalization with heart failure and heart failure death benefit. However, in this study, dapagliflozin was not being shown to have cardiovascular or mortality benefit. The DABA heart failure trial, again, in people with reduced ejection fraction of 40 or less, dapagliflozin have been shown to reduce the heart failure and death from heart failure. And again, this is one of the important studies and one of the first studies that have demonstrated the benefit of this class of drug and this drug in people in the absence of diabetes. So this drug could be helpful even in people without diabetes. And when it comes to renal outcome, the EMBA-REG trial with empagliflozin, again, despite the earlier dip of EGFR, however, it has been shown that the EGFR will be maintained and even better than the placebo, with relative risk reduction of progression to albuminuria by 38%. And this is translated to lower rate of renal events and worsening nephropathy. So empagliflozin is associated with renal benefit. Similarly, in the Credence trial in people with diabetes and albuminuria chronic kidney disease, people who receive canagliflozin have better renal outcome as compared to the placebo group. Similarly, in the latest trial in this class, the DABA chronic kidney disease trial in people with reduced EGFR, again, they found that dapagliflozin is associated with renal benefit. And again, this is one of the first trials that shown that this drug may be also beneficial in people even without diabetes, in the absence of diabetes. So to summarize the SGLT2 inhibitor results, cardiovascular outcome trial, you can see that EMBA, CANA have shown cardiovascular and heart failure benefit. Dapagliflozin have been shown mainly the positive heart failure benefit, and with the hierarchy and the preference to empagliflozin, because empagliflozin have shown additional mortality benefit as proven in the EMBA-REG outcome, which was not proven in the other trials. When it comes to renal outcome, EMBA, CANA, and dapagliflozin all have shown positive renal outcome and related to the improvement of the glomerular hemodynamic functions. Insulin, again, we know that people with type 2 diabetes ultimately may require insulin. However, we are lucky to have a newer insulin analog that mimic the normal physiology with less hypoglycemia and less weight gain. These are the classes, these are the drugs that we have in this group, the insulin. We have the rapid-acting insulin, we have the first-generation basal insulin, and we have the second-generation basal insulin like glargine 300 and Dogludic 100 and 200. And we have also the biosimilar basilar insulin that is produced by Lilly biosimilar to glargine U100 made by Sanofi. So the advantage of the rapid acting, more flexibility of the injection of the insulin immediately before meal or after meal even, and the second generation basal insulin with the more predictable action with lower risk of hypoglycemia and less variability. And also with the basilar insulin that has lower price for people who cannot afford the high price of those insulin. Why we talk about insulin? Because we know that hypoglycemia is a major complication of insulin. And we know that hypoglycemia is associated with increased cardiovascular event. So we need to prove a safety profile of the insulin with lower risk of hypoglycemia and cardiovascular safety. And actually, in the origin trial with glargine, it has been proven that insulin glargine has a neutral effect on cardiovascular outcome with no increased risk for heart failure or cardiovascular disease. In another trial, the VOTE trial, they compared the Dogludic, the second generation basal insulin, to the glargine U100, the first generation basal insulin. And what they found in this study that the first generation the first generation insulin, like glargine U300, has higher risk of severe hypoglycemia and nocturnal hypoglycemia as compared to Dogludic insulin, the second generation basal insulin. However, when it comes to the cardiovascular outcome, both basal insulin, Dogludic and glargine, had safety profile with no increased risk for cardiovascular disease or heart failure, despite the increased risk of hypoglycemia with the first generation basal insulin. And again, to note in this study, there was no association between severe hypoglycemia and subsequent heart failure. In elderly, again, they are vulnerable group. In the addition trial in people over the age of 65, they compared glargine U 300, second generation, with glargine U 100, first generation, and they found that the second generation had lower risk for nocturnal and severe hypoglycemic events. So to conclude the basal insulin cardiovascular outcome, again, all basal insulin, the first generation and second generation basal insulin, they have neutral cardiovascular safety profile. However, the second generation had lower risk for hypoglycemia as compared to first generation basal insulin. Now we have also a new drug that combine the insulin with incretin in the same syringe, and we have two drugs in this approved in this class, and that probably give the complementary effect and probably the added benefit of the GLP-1 to insulin, reducing the risk of hypoglycemia. So how now do we fit those cardiovascular outcome in the guidelines? Do the updated guidelines help us to select the best diabetes treatment? We have seen the results of the cardiovascular outcome and the growth of those results, and those results have definitely impacted not only the diabetes guidelines and recommendation, but also the cardiovascular, heart failure, and kidney disease guidelines and recommendation. I will start with 2015 ADA recommendation. At that time, our focus were only on glycemic control and A1C, and the key changes in these guidelines were only the addition of the new classes of DDB4 inhibitor and GLP-1 receptor agonist. Our focus was glucose center with no specific drug preference. In 2015, again, our focus is glucose centered, and the key change is only adding the SGLT2 inhibitor to the class with no preference to any drug. And again, it is glucose centered rather than drug or patient centered. In 2015, again, it's glucose centered, and you have all the drugs and you choose whatever you feel is suitable with the patients, and this is glucose centered. However, in 2017, this is the first time we started talking about those results about the empagliflozin and liraglutide, and they have recommended that if you have a patient with established disease, then preferably you should use empagliflozin or liraglutide for the treatment of those people. And subsequently, those recommendations have been translated to the January 2018 recommendation, and they addressed a question. If a patient has atherosclerotic cardiovascular disease, then you should select a drug with proven benefit like GLP-1 receptor agonist and SGLT2 inhibitor. And actually, in the same year, October 2018, the guidelines have changed again for the second time to, rather than becoming more complex, but rather to include all those important trials of the cardiovascular outcome trial in terms of the recommendation of the treatment. And what happened in October 2018, the guidelines have changed its shape from glucose center to patient center. And for the first time, they addressed after metformin, if the patient has established cardiovascular disease, and based on the studies that we have mentioned, then GLP-1 receptor agonist or SGLT2 inhibitor should be selected. Similarly, if a patient has kidney disease or heart failure. If this is addressed, then you should look for other factors like hypoglycemia, weight gain, and cost. So this is for the first time, again, we have a patient-centered approach with drug preference. And actually, this is the hierarchy for the treatment. They mentioned that if the patient has atherosclerotic cardiovascular disease, then the preference is for GLP-1 receptor agonist, and the hierarchy is for liraglutide, then semaglutide, then exenatide. This is based on the results that I have mentioned to you, and dulaglutide have been added in 2019 for the results that have been mentioned. And if not, you may add or substitute GLP-1 if not suitable with SGLT2 inhibitor, and again, preference for EMBA and then canagliflozin, because EMBA have added mortality benefit. If the patient has chronic kidney disease or heart failure, then the preference is for SGLT2 inhibitor, and both EMBA and CANA, they have the same benefit for heart failure and kidney disease, and dapagliflozin have been added in 2019. If this is not enough or not suitable, then liraglutide is a drug of choice, and dulaglutide have been added recently. And if the patient still is not controlled, you can choose any of the other classes of drug, and better to avoid saxagliptin and bioglitazone in people with heart failure. If you are concerned about weight, then the best drug of choice will be GLP-1 receptor agonist, then SGLT2 inhibitor. And this is the hierarchy: semaglutide, then liraglutide, then dulaglutide. Why semaglutide first? Because I have shown to you that semaglutide have provided more additional weight reduction of up to 6 kilograms. If this is not suitable, then you can add more drugs. If you are concerned about hypoglycemia, then these are the classes of drug that have shown to have reduced risk for hypoglycemia. Then if insulin is required, then you should preferably use the second generation basal insulin, better than the first generation and better than MPH. If you need to use sulfonylurea, then gliclazide and then glimepiride, and should avoid the older generation sulfonylurea because they increase the risk of hypoglycemia. If cost is a concern, then sulfonylurea and TZDs is the lowest in price, or you may use, if you need insulin, you may use the insulin like basal insulin with low cost, that like Basal that I have shown to you earlier. What are the changes in 2019 ADA recommendation? Again, we have established atherosclerotic cardiovascular disease with preference to GLP-1 and SGLT2 inhibitor, patient-centered, and based on those trials. And here we had the Rewind trial, dulaglutide. And in this year, we started talking about the benefit in people at risk and irrespective or independent of the baseline hemoglobin A1C. And this was soon translated in the 2020 guidelines. And they have mentioned that if you have a patient with established or at risk of chronic kidney disease or cardiovascular disease or heart failure, and irrespective of the A1C, you should select a drug with additional benefit like GLP-1 receptor or SGLT2 inhibitor. And here also, we started also, because of the Rewind trial, again, as I mentioned, we talked about people at risk. In 2021, what are the changes in the 2021? Here, as you can see, we have separated the heart failure from the kidney, and we have here even looking at people with low ejection fraction with preference to SGLT2 inhibitor. And here we started talking about, even because of the DABA heart failure results, we've talking again, people at risk and also irrespective of hemoglobin A1C or metformin. Here we have even irrespective of metformin, even before you start patient on metformin, you may consider GLP-1 receptor agonist or SGLT2 inhibitor. So how would we summarize those all guidelines in terms of the profile and strategies in people with type 2 diabetes? Again, metformin should remain the first line. If you have a patient with concerned about hypoglycemia, then based on your patient hyperglycemia and A1C, you should select drugs, and this is a hierarchy of drug from best to less favorable. If you have concern about hypoglycemia, then preferably you should start GLP-1 receptor agonist and or SGLT2 inhibitor and or DDP4 inhibitor. You need to know that you should not combine DDP4 inhibitor with GLP-1 receptor agonist because they belong to the same class. Now, if you have a patient with heart failure, cardiovascular disease, or chronic kidney disease, then independent of the hemoglobin A1C as 2020 guidelines, and also independent of the metformin as recommendations 2021, you should select SGLT2 inhibitor and or GLP-1 receptor agonist for people with chronic kidney disease with the hierarchy as mentioned here for the reason I have told you earlier. And if you have a patient with heart failure, then SGLT2 inhibitor and or GLP-1 receptor agonist, and if cardiovascular, GLP-1 receptor agonist and or SGLT2 inhibitor. If your patient still is not at target, then based on the glycemic control, you may add other drugs with a neutral effect and cardiovascular safety. You should avoid glitazone and saxagliptin in people with heart failure. Again, here in metformin naive, if you have a patient not yet on metformin, you have just diagnosed him. If the patient has insulin resistance, then you should preferably select metformin, and then you add drugs based on the glycemic control. If you have a patient at high risk or very high risk, and they are not yet on metformin, whatever the tool you use to stratify this patient, then your first drug of choice should be GLP-1 receptor agonist and or SGLT2 inhibitor. And if not at target, then you may add metformin or other classes of drugs. So what does the other diabetes guidelines recommend? Australian guidelines, again, in the second line and third line. Here, you should focus on the cardiovascular, heart failure, renal, and hypoglycemia, and select drugs with a safety profile and benefit if possible. In the ACE guidelines, again, they addressed even independent of the A1C if the patient has established or at risk for cardiovascular disease, heart failure, or renal. Again, you should use GLP-1 receptor or SGLT2 inhibitor. And in the Canadian guidelines, again, metformin is the first line. If you have a patient with established cardiovascular or renal disease, then the choice will be for GLP-1 receptor agonist and SGLT2 inhibitor. If not, then if they are at risk, again, you should select drugs like GLP-1 receptor agonist or GLP-1 or SGLT2 inhibitor. And if not, then you can use drug with safety cardiovascular profile. The American Heart Association, what did they recommend? They recommended, again, metformin should be the first line because it has an addition, it has a cardiovascular benefit. If not, again, you may add also a SGLT2 inhibitor or GLP-1 receptor agonist for their added benefit for cardiovascular risk. European Society for Cardiology, this is the latest, again recommended if the patient is naive, not on any treatment, should start with GLP-1 receptor agonist or SGLT2 inhibitor. If the patient is already on metformin, then you continue with metformin and add SGLT2 inhibitor or GLP-1 receptor agonist. If at risk for heart failure, then the choice should be for SGLT2 inhibitor. What about the renal guidelines? Again, renal guidelines recommended if you have a patient with type 2 diabetes and GFR below 60 or GFR above 60 with microalbuminuria or macroalbuminuria, then you should add or substitute one drug for SGLT2 inhibitor. And if this is not enough to bring blood glucose to target, then you may add another drug like GLP-1 receptor agonist, as we have mentioned, for their added benefit on the macroalbuminuria. So ladies and gentlemen, how do we translate all this in one slide? How, this is from endocrine point of view, how we will manage our patient in year 2021. So for example, if you have a patient diagnosed with type 2 diabetes, the option is to initiate metformin with lifestyle management. I think all agree about this. If not at goal, then you should ask your patient if he has an established cardiovascular disease, heart failure, or kidney disease, or at risk for those. Then if no, you should address other things like hypoglycemia, weight loss, and cost. If yes, then you should add a drug with proven or reduced cardiovascular event and mortality. You may ask if we can substitute this step to here above. Irrespective of metformin, you should start your patient with classes with proven benefit. Yes, the guidelines now moving toward this. Or you may also, and this is what I prefer, you may add metformin to the dose classes GLP-1 or SGLT2 inhibitor with benefit effect, irrespective of the A1C. I prefer this because we know the benefit of early combination therapy in preventing the beta cell exhaustion and also delaying the treatment failure. So if the patient has established cardiovascular or renal disease, if it is renal disease, then this is the drugs that you choose, SGLT2 inhibitor and or GLP-1 receptor agonist, and this is the hierarchy based on the studies. And if your patient has cardiovascular disease and with the component is heart failure, then your preference is for SGLT2 inhibitor. All of the EMBA, CANA, DABA had similar results. If it is cardiovascular disease, then preference is for GLP-1 receptor agonist, and if not, add SGLT2 inhibitor with preference to empagliflozin and liraglutide for their added mortality benefit. If the patient at risk, we should handle them as people with established cardiovascular disease, and if they are not at target, then move to adding more drugs. And actually, this is discussing the early combination. In the latest ADA, they recommended early combination to extend the time to treatment failure, especially if the A1C is more than 1.5%. Similarly, in the ACE, if the A1C is above 7.5%, then they recommend dual therapy or triple therapy. So we have seen cardiovascular disease is really wide spectrum. You can see very, very wide spectrum. We have different scenarios of heart disease. And luckily, we have at least 4 classes of diabetes drug that have shown benefit in people with various cardiovascular disease, whether they have diabetes or even in the absence of diabetes. However, we need future trial to target combination therapy, whether combination of 2 drugs may add cardiovascular benefit or not. So in conclusion, ladies and gentlemen, both SGLT2 and GLP-1 receptor agonists, on top of their glucose lowering activity, they have cardiovascular protection. Treatment decision should not be solely based on glycemic control, but also addressing organ damage and reduce morbid mortality. And as we know, cardiovascular outcome trial nowadays primarily evaluate the safety rather than the glycemic benefit. We have to keep this in mind. And also finding from cardiovascular safety and outcome trial have definitely changed the diabetes guidelines, as I have shown you. We have had evolution of cardiodiabetology. We moved from glucose-centered approach in 2018 and earlier, targeting disability disability with complications like retinopathy, nephropathy, and neuropathy, to more focused and patient-centered approach, focusing on the morbid mortality with reducing the risk of myocardial infarction, stroke, death, hospitalization with heart failure, kidney disease progression, in addition to complication. So we moved in the past 15 years from expert opinion guidelines and recommendation to the evidence-based guidelines and recommendation. And we have seen the significant evolution of guidelines from year 2015 to 2021. And we are waiting for more cardiovascular outcome trial that may further impact on treatment preference for people with or without diabetes, people with established or people at risk of complication. And with that, I would like to thank you very much.
Thank you, Prof. Ibtisam, for this comprehensive review of the management of type 2 diabetes. Now we'll receive questions for 10 minutes, then we'll have a break. So please, if anybody has a question, we'll send it through the chat or Q&A icon, please send. One question here, what's the effect of selective glucose transporter 2 inhibitors in fatty liver? Is there any effect study should that beneficial for fatty liver? If anyone of the speakers want to answer this.
Question is for who, me or Dr. Ryan?
One can answer it, please.
As far as I know, in regard to safety, there is no issues with a safety issue with the liver disease because of the metabolism, as we mentioned, of this drug and the pathophysiology of that drug. However, I have not seen any study looking at the benefit in fatty liver. I mean, if you have a patient with fatty liver, we know the drugs that have shown benefit is the TZDs, vioglitazone, and plus minus the benefit also of metformin for insulin resistance.
Okay. Any more question, please, in the chat? Let me to check. They are asking if there is CME-hours. I think there is CME-hours. Any question, please? I want to ask, what's the lower limit of the estimated glomerular filtration rate you can start selective glucose transporter 2 inhibitors?
Yeah, thank you, Dr. Nasser, for your for these questions. I mean, the lower limit, usually we start, if the GFR is normal, up to 45, we can initiate. But if deteriorating less than 30, we should stop this kind of class of medication.
So stop it below 30?
Yes, please. And you can initiate if the GFR more than 60 and up to 45, you can initiate. But if it's coming less than 30 deterioration, you should stop.
If you allow me to comment, also, actually, we know that why it is above 60 is for the glucose benefit, because you need a good renal tubular function in order for the glucose benefit to occur. However, now they are going down with this eGFR, as Dr. Raed mentioned, for the other benefit rather than even the glucose benefit. So we are waiting for the future also to see whether it will have even more benefit if at lower eGFR. So the benefit is rather for the other cardiovascular and renal benefit rather than the glucose benefit at a lower eGFR.
Yeah, but according to recommendation.
Yes, not you should, if the patient initiation 60, if patient is already on treatment, you may continue up to 45, yes.
Very good. So please submit your question if you have any question or comment. What's the difference between, for example, selective glucose transporter and AC inhibitor or ARB? We know that we can use ARB in some patients with a proteinuria without hypertension. So what do you think the difference? Which will be the best? If you have a patient already has a proteinuria, diabetic, and he's not hypertensive, so we'll start AC inhibitors or selective glucose transporter inhibitors if he's type 2 diabetes.
Actually, thank you for this question. It's a very nice question. The SGLT2, the AC inhibitor can be used for those patients with type 2 diabetes, and the studies showing that it's decreasing progression to macroalbuminuria. However, the AC inhibitors also can be used for those patients non-diabetic. The SGLT2 inhibitors, they have different mechanism of action to decrease albuminuria and progression to chronic kidney disease. So it's two different kind of medication, and we can use them with each other. Using another medication, it's not it's not meaning that to stop the other one.
Very good. So if the patient already has developed urinary tract infection, do you advise will continue or will discontinue the treatment with selective glucose transporter inhibitors? Any one of you can answer this?
If you want me to answer, actually the risk, as we mentioned, is really very low, and also the infection is really minor and mild, and most of the time it does not require stopping the treatment. You can treat the infection, whether it depends whether it's urinary tract or genital infection, while the patient is on treatment. If it is mild, usually it is self-limiting and you don't need to discontinue the treatment.
Very good. Maybe we'll ask another question because there is no question.
There is a question about metformin. If you allow me to answer that question, there was a question: what is the maximum dose of metformin in patient with creatinine more than 1.5 milligram per deciliter? So to answer this question, actually, it's better to follow the eGFR rather than the creatinine level. So if you have a GFR below 30, then you should stop the metformin. This is according to the latest guideline. If you have an eGFR between 30 and 45, then you should use half of the dose. If we say that the recommended dose is 2 grams, then you can use up to 1 gram, not more than this. If the eGFR is above 60, then you can use the full dose of metformin.
Very good. Any more question? In a study, they compare the use of selective glucose transporter inhibitors to inhibitors and GLP-1 receptor agonist combination. They look for renal outcome or cardiovascular outcome. You aware any study?
Actually, I'm not aware. I reviewed it, and this is why I put this open-ended recommendation at the end. We need actually to look at added benefit. Even metformin, for example, if I add metformin to GLP-1 or SGLT2, we know that metformin has cardiovascular benefit. So if I add metformin with GLP-1 receptor agonist, or I add GLP-1 with SGLT2 inhibitor, do I get additional cardiovascular or renal benefit? I think this should be addressed in the future studies with cardiovascular outcome. I'm not aware about studies that looked at the added benefit. I don't know if Dr. Raed would like to comment.
Yeah, I agree with you, Dr. About this. Yes, I totally agree with you. There is no, till now, there is clear guideline for this.
Yes, selective glucose transporter 2 inhibitor is superior to GLP-1 regarding heart failure and chronic kidney disease or diabetic kidney disease. What's about a patient come with in mind? What we prefer? Do we prefer GLP-1 receptor agonist or selective glucose transporter when we choose which one?
I think I have shown to you in the studies and recommendations. Actually, the earlier study, they were recommending GLP-1 preferable to SGLT2 inhibitor as the added benefit. However, the latest guidelines and recommendation, they put them both together, GLP-1 or SGLT2 inhibitor, either one of them, and if the patient cannot tolerate one, you can use the other, and if the patient is not at target, you can use both of them.
Okay. One ask about the actis in cancer testis. Anyway, so in 30 seconds, Dr. Ibtisam, what's your recommendation or your conclusion from this presentation?
Actually, my conclusion is we can see the evolution and the recommendation and the guidelines, and I give you in one slide how do you look to your patients, and it depends if you are just diagnosing your patient with type 2 diabetes. I believe that metformin should remain the first line therapy for its added benefit and for cardiovascular benefit as well. And you should always address, before you address any other issue, before you look at the A1C, before you look at anything, you should always ask your patient or look at if the patient has established cardiovascular disease, renal disease, or at risk even of renal disease or cardiovascular disease or heart failure. Then you should immediately start with one of the drugs that have proven benefit to either heart failure or cardiovascular disease, or even combine them if the patient is still not at A1C target.
Thank you very much. Dr. Ryan.
Yeah, at the end, maybe my last conclusions that the body is connected to each other. So the diabetes is not affecting only by itself, it's affecting cardiorenal. So if you want to choose the appropriate, I mean, the class of medication in diabetes or hypertension or others, try to choose the most appropriate one that can help you in controlling diabetes and decreasing other risk factors. Thank you.
Right. When asking about dialysis, so there is no use, not used in dialysis, as they said, the speaker. Don't use selective glucose transporter inhibitors if estimated filtration rate below 45. So thank you for all speakers. Thank you, Dr. Raed. Thank you, Dr. Abdesam. Thank you, all audience, actually. Now we'll have a break for 10 minutes, okay? And in this in between, I want to thank Saudi Heart Association and Boehringers for this rich, actually, scientific presentation. So please sharp at 2:30 p.m. please come, because there are other 4 interested actually presentation. So thank you for you. See you after 10 minutes. Welcome back again for our rich academic activities. The second session start with Prof. Kamal Al-Ghalayini. He is consultant cardiologist and heart failure specialist at Abdulaziz University Hospital. He has many presentations and research. I think you will enjoy his talk really. He will talk about Emperor reduced a late-breaking trial in cardiovascular and renal outcome with empagliflozin heart failure. So talk about the use of guardians or empagliflozin in heart failures. Welcome, Prof. Kamal, and the stage is yours. So we'll have 30 minutes to talk about the role of empagliflozin in heart failure.
Thank you very much, Mr. Chairman. Bismillah, salatu salam ala rasulillah. Good afternoon, everybody. Jum'ah Mubarakah for everybody, hopefully. And I hope we will enjoy the rest of the day. So I'm a cardiologist talking among billions endocrinologists, but that's life. Nothing is the same, always change. Now we are sharing an extremely important classes of medication that are highly effective in our practice of heart failure. So without further delay, I hope my screen is clear.
Yes, yes. Enlarge it, please. Expand it, okay. Well,
so we will look at the new horizon of the futuristic medicine, empagliflozin, and heart failure with reduced ejection fraction. And as Mr. Chairman mentioned, some views on the renal protection and so. This is my disclosure. I'm a speaker for Ringer England Hives. So we have 3 major topics today. What we already know about heart failure, and empagliflozin, the heart failure new kid on the block, as we are saying right now for heart failure patients, and have a look on the latest Emperor reduced trial, which is another milestone to achieve in our battle against this disease. What do we know? We know that it's a serious disease. More than 60 million people around the world. In Saudi Arabia here, we have something between 450,000 and 500,000 patients, as mentioned in the Hearts of Saudi registry. And we know that it's a killer disease, so we lose almost 50% of our patients in 5 days, in 5 years, and we lose almost 70% of them when the heart failure comes with cardiogenic shock and admitted to intensive care. Now, hospitalization is the #1 enemy for the heart failure care physician and the heart failure patient and his family. It is the #1 cause of hospitalizations for patients more than 65 years old. The readmission is unbelievable. I mean, heart failure hospitalization is one of the worst key factor indicator in any practice. It has as high as 30% in 60 or 90 days, and almost 30%, unfortunately, of our patients who are hospitalized die within 1 year. So from there, we also need to remember 2 things that that are defined as heart failure: the reduced ejection fraction and the preserved ejection fraction, and the added one in between, borderline or mid-range heart failure. And the mortality is very clear in the reduced ejection fraction. Unfortunately, we're waiting for a lot of trials to come up and support us with some disease-modifying or mortality-modifying molecules for preserved ejection fraction. So today we will concentrate on reduced ejection fraction. Now, data on SGLT2 and heart failure has been there for quite some time. And it all started with empagliflozin that showed the reduction in hospitalization, cardiovascular death, and in kidney outcome. Was a brilliant trial done on diabetic patients and showed these beautiful results. And actually, that was the eye-opening for the effect of these new molecules on the one of the target organs, which is the heart. And then Canvas come up, particular, and Veritas Cardiovascular. They all showed here and there an improvement of all these solid outcome measures. So the story of SGLT inhibitor started, as I mentioned, with the type 2 diabetes patients, with the empiric outcomes in the area of heart failure prevention. Now we're talking about heart failure treatment, and we have the two mega trial results: the DAPA-HF, which was published and about more than a year ago, and the Emperor Reduced, which was only published last August. Now, few theories comes out on how does the SGLT2 inhibitor function in delivering these very good endpoints and outcomes. And all theories act together and they all make sense. From the natriuresis part, to improve kidney function and to improve the cardiorenal physiology, reflexes that we know in heart failure, to reduce the preload and afterload, which has a tremendous effect on reduction in the left ventricular wall stress. And finally, with a reduction on the interstitial edema, that is actually a very, very important pathophysiology part of heart failure. Now, the unique thing about diuretic effect, diuresis effect of SGLT2 inhibitor, is we know that it is not the primary thing, and we're not giving it for the diuresis, but with the diuretic effect that it has, it selectively reduces the interstitial volume with minimal change of blood volume. There is no counter-regulatory stimulation for RAS system or nitric oxide activation. There is no hypokalemia, and there is actually an evidence for improvement of renal function and reduction of uric acid, which is always a challenge when we use our regular loop diuretic medication in our heart failure patients. Now, the benefit effect when we compare it to other disease-modifying agents like ACE, ARBs, beta blocker, mineralocorticoids, antagonist, diuretics, and ARNI, we find that each one of these has some benefits from one part or another. But look at the SGLT; it managed to score an evidence benefit on all four aspects: on natriuresis, on renal function protection and even improvement, on the preload afterload, as I mentioned, and on the interstitial edema, which we only experience when we use our diuretics in heart failure patients. That's a slide that looks at the timeline that SGLT2 inhibitor played in the heart failure management course, and it started with as I mentioned, with the declaration of the DAPA-HF on the third quarter of 2019 on the European Society of Cardiology, and then the declaration of Emperor Reduced also on the third quarter with the ESC, and then we're looking forward for the results of Emperor Preserved and Deliver, which will come probably, inshallah, with the first and second quarter. And these two trials actually are designed to prove the benefits for the heart failure with preserved ejection fraction. We're really hoping for that in the coming year. Now, this is what we know. We already know. We're just refreshing and reminding each other. And let's look at the empagliflozin itself. What is it? It's part of the Empower, which is a huge cardiovascular metabolic program. And it has a lot of trials. Some trials started with emperor-reduced, emperor-preserved, 3 and 5 months, almost 6,000 patients for the preserved part. And then we have the empiric outcome. And then finally, we have the Emprise, which is something like 230,000 patients, which is a real-world effectiveness in patients with type 2 diabetes in the States. Not the States alone, excuse me, not the States alone, but States, Europe, and Asia. So this is where the empagliflozin is being tested and has been tested in different aspects. And the US FDA fast track decision came after the brilliant outcome or an announcement of the emperor reduced, and it has been placed there for the treatment of chronic heart failure and improvement outcome. Now we keep saying emperor reduced, emperor reduced. Let's look at this trial. What does it say? How was it built, and what does it tell us? As I mentioned, it was announced in the European Society of Congress, the digital experience. I believe we've all been there digitally. So emperor reduced is to assess the safety and efficacy of empagliflozin versus placebo on top of guideline-directed medical therapy in patients with heart failure with reduced fraction. This trial has the potential to shape the future of empagliflozin as a treatment option for millions of patients with heart failure all over the world, as we mentioned. The elegant design, was, as I mentioned, to investigate the safety. And the population was type 2 diabetes and non-type 2 diabetes. And we will talk about the inclusion and exclusion criteria. So the design was a randomization of 3,700 patients to 2 arms. The empagliflozin 10 milligram once daily, plus the standard of care, which is the guideline-directed medical therapy. And the other arm will receive placebo, plus the guideline-directed medical therapy. And we have a median follow-up of 16 months. Now, the endpoints is composite primary endpoint means of time to first events of adjudicated cardiovascular death and adjudicated also heart failure hospitalization. Now, secondary endpoints, which we all know and use as exploratory endpoints, is the first and recurrent adjudicated heart failure hospitalization event, plus the slope of change in the estimated GFR from baseline. So this is the inclusion and exclusion criteria. 18 years. In Japan, for some linguistic reason, it was more than 20. So heart failure with New York Heart Association classification of 2 to 4. Then the BMP was designed upon the ejection fraction. 36 to 40, we needed BMP of pro-BMP of more than 2,500. 31 to 35, we come down to the pro-BMP to 1,000. Less than 30, the trial accepts pro-BMP of 600 and more. Now, the exclusion criteria is extremely important. Empagliflozin was not tested in acute myocardial infarction, was not tested in patients who had 90 days, within the 90 days of stroke, cardiovascular surgery, TIA, or coronary artery bypass grafting. Was not tested on the heart transplant recipient, on acute decompensating heart failure. Please, this is very important. And it was not tested for blood pressure on the extremes, I mean, less than 100 or more than 180 for 2 visits. But the good thing is that it was tested for as low as estimated GFR of 20. Now, this is the lowest, up to my knowledge, GFR that heart failure medication was tested. All other medications, ARNI and empagliflozin, were tested as low as 30. So what happens to the outcome? The outcomes were, as I mentioned, the adjudicated cardiovascular death or heart failure hospitalization. The secondary outcome would be adjudicated first and recurrent heart failure hospitalization, and lastly, the estimated GFR. And Emperor-reduced has managed to reach these three outcomes. How? Primary endpoint, cardiovascular death. The two curves have split extremely early before even hitting the 90 days of randomization and reaching an overall relative risk reduction of 25% and number needed to treat 19. And that's, up to my knowledge, the lowest number needed to treat in this subgroup, in this group of SGLT2 inhibitor. And as we can see here, the numbers starts to shape up and spread from the very early. We're talking about number sides, and which keep growing and growing and growing until the end of the trial. What about the hospitalization part, first and recurrent? Again, we have a relative risk reduction of 30% with a p-value of 0.001 of statistical significance. And again, the numbers start splitting from as early as the randomization. And the total events for the empagliflozin was 388 compared to 553 events in the placebo arm. Let me just remind you that both arms were on fully guideline-directed medication for heart failure treatment. Now, that is a very important curve to understand. We have two lines to look at the estimated GFR, and what we call slope. So simply, if you are using empagliflozin, you will have this purple, almost plus or minus, going to a horizontal line. But if you are using the placebo, meaning that you're treating your heart failure with all guideline-directed medication, but you're not using empagliflozin, then the ejection fraction, the estimated GFR in heart failure patients will drop tremendously. And this study has shown that the p-value of statistical significance was 0.001, and there is a clear decline on the rate of renal GFR, estimated GFR, and it keep growing until 3 years, which were the announcement of that trial. Now, we come back to this interesting slide, which that the Emperor-reduced has reached the 3 endpoints for specified for the testing for that trial, which again, cardiovascular death, the adjudicated, and then hospitalization with secondary endpoints of either recurrent hospitalization or primary hospitalization and estimated GFR. So what about the efficacy? Shall we explore the endpoints together? Look at the composite renal endpoint for kidney disease. And here, we found that there is a 50% improvement of risk and relative risk reduction in the empagliflozin and the placebo group. And as you can see that the marked deviation of the two curves did not occur early, but it did occur after the 7-month follow-up. But then it continued to be separated and go on and go on and go on. And you can see that the area under the curve for the placebo is almost double the area under the curve for the empagliflozin, which is translated into 50% relative risk reduction. And this is very, very important part. I mean, we all treat our patients so they can enjoy a good quality of life. And this can be measured by so many tools in heart failure. One of them is called Kansas City Cardiomyopathy Questionnaire. It's a holistic questionnaire that's filled by the patient himself. and you take a baseline and you follow up on 3 different equations that was done. And I will simply tell you that the quality of life for patients who received the empagliflozin improved with a proven statistical p-value of 0.0058. And that is something that us as heart failure specialists really care about, and we insist to hear from the patient and his family for every visit on how is the quality of life has improved in all medication, in all education, in all dietitian programming. This is what matters for us, because we believe that there is a very strong link between improving quality of life for heart failure patients, hospitalization, and at the end, mortality. What about it? What about the safety part? This is a drug that's coming on top of other drugs, and a very complicated drugs. The average heart failure patient receives something like 7 to 9 drugs on a daily basis, countless numbers of tablets. And if the patient is diabetic and receiving injections with one or any diabetic injections, so you're talking about a lot of drugs in a simple word of polypharmacy. Adding something and adding a new molecule, you really need to know that is it safe to do that. So heart failure with reduced ejection fraction, safety profile, type 2, and without type 2 diabetes, and the GFR effect. Now, this is what we look at. If we compare the empagliflozin arm with the placebo arm, we will find that areas for volume depletion, hypotension, symptomatic hypotension, ketoacidosis, and all form, we will find that there isn't a statistically significant difference between the two arms. Some of them we can find numeric difference, like for example, volume depletion, 197 in the empagliflozin, 184 in the placebo arm, but these are statistically not significant, and so on and so on. So it is considered a safe drug to add to our polypharmacy. About the results, we have the first eye-opening trial, which was the EMPEROR. So it looked at benefits of cardiovascular, renal, and metabolic outcomes in patients with type 2 diabetes only. But EMPEROR reduced at these outcomes in heart failure patients with and without type 2 diabetes. And again, we have, this is a timeline again to remind us the difference between what we had at the EMPEROR and what is coming. So the EMPEROR juice is coming here, and then we are looking for the EMPEROR preserved. All these came from that beautiful EMPEROR trial that was held earlier, and the impulse. If we have like a snapshot for all trials that looked at the heart failure patients recently, we have the EMPEROR juice. Just before it, we had the DAPA-HF. A few years before it, we have the Paradigm-HF for the ARNI group, and then we have the Victoria. And if you can excuse me for the busy slide, but let's look at the hazard ratio. So hazard ratio tells us that the EMPEROR juice has shown a relative risk reduction of heart failure hospitalization and cardiovascular death by 25%, DAPA-HF by 26%, Paradigm-HF by 20%, and the Victoria but only 9%. But then we look at the number needed to treat, and we find that the EMPEROR juice trial has showed us that it's the minimum number of treat for 19 patients over 16 months, and then we have for the DAPA-HF 21 patients over 18 months, and then we have the Paradigm-HF, which is 21 patients over 27 months, and then the Victoria. Victoria is looking at these results for Victoria came out for much sicker patients, so it is not really in the context of the patient profile, but it looks at heart failure with reduced ejection fraction. So this is the point that we need to understand, that when we compare two trials, it's more or less just an eye-opening. But if you want to compare two molecules, you have to put them together in a randomized controlled trial together. So to compare empagliflozin and dapagliflozin, it's hypothetically compared in this because you compare the two trials. But if you really want to compare them, you need to put them together in one trial. And we will never do that because we have a great effect in both ways. So no need to go and exhaust further effort. So the relevant adverse effect for both trials showed that compared to placebo, really didn't show much. Maybe numeric evidence on the DAPA-HF came from ketoacidosis. Amputation also only numeric effect more of the empagliflozin. Bone fraction also only, but none of them were statistically significant when it comes to comparison. What about the dosing and titration? Very important. When you look at SGLT2 inhibitor, you don't titrate, single dose, and that's it, once daily. When you start, you just continue. We all know the agony that we go through, the multiple visits, the multiple phone calls, the multiple continuation, that when you start ACE or RA or ARB, and even when you go for ARNI, you need to keep up titration with looking at the blood pressure, probably a lot of blood investigations, as we all know, for the heart rate. But this is a new kid that you can rely on, SGLT2 inhibitor. You don't need to up titrate, you just give the recommended dose, like for empagliflozin, 10 milligram once daily, and that's it, and you go on. What about the electrolyte imbalance? This is the most difficult part on treating heart failure patients after hypotension, is the potassium. MRA brings it up, look diuretics brings it down, and we keep going from up and down. But look at the SGLT2 inhibitor, it doesn't really affect much on potassium. Thiazide definitely bring it up, and so on. Yes. Now, final two slides just to wrap up, and this is an open question. I really don't know. Maybe I have an impression, but I don't know. This is the algorithm that we all practice our heart failure treatment on. So it was the 2016 announcement in the ESC conference for heart failure with reduced ejection fraction. We all start our patient on ACE and beta blocker. Up titration, still symptomatic, we add an MRA. Up titration, still symptomatic, we switch the ACE and ARB to ARNI. Probably look at the QRS. If it's more than 130, we will be discussing CRT. And if the rhythm is more than 70, then probably we'll put an ivabradine. Lasix is all over the place. We put it anytime whenever there are symptoms that we need to control. And the implementation of ICD is for patients with fracture distance for the 35%. Now, if all this failed, then we will discuss the possibility of assist devices or transplantation. Finally, this is a take-home message. To carry your heart failure patient, you need 4 pillars before. Now you need 5 pillars. The 4 pillars used to be ARNI in change for ACE and ARB, MRA, beta blocker, and now definitely with all these data, we have a SGLT2 inhibitor that has to be there for our heart failure reduced ejection fraction. With this, ladies and gentlemen, Mr. Chairman, I would conclude, and thank you very much for your time that's given to me. Hope I'm on time.
Thank you, Prof. Kamal, for finishing the time. Thank you for this excellent presentation. Please stay with us till the end of the next discussion. Thank you very much, Dr. Kamal. The second presentation today will be about the potential role of selective glucose transporter inhibitors in with chronic kidney disease. Our next speaker is Prof. Abdul Mahfouz. He is the head of endocrine section at the King Faisal Specialist Hospital and Research Center in Riyadh. He is a well-known speaker. I think he will give us about the potential role of empagliflozin and chronic kidney disease. Welcome, Prof. Mahfouz. You can share your slide. Okay. Present.
Thank you very much, Nasser, for this nice introduction, and I would like to take this opportunity to thank the organizers for asking me to be part of this lovely the webinar. Over the years, and for those who have actually followed the topic, you will see that we have made a lot of strides over the last few years as compared to the previous 20 years. Here are my disclosures. And this is the content of my presentation. So I'm going just to start with kidney disease burden, just to highlight the importance of kidney disease in diabetics. Then I'm going to go through the chronic kidney disease outcome from cardiovascular studies. And then I'll briefly mention and share with you the CKD dedicated study, and I'll end up my talk with summary. All right, as this slide shows, the prevalence of chronic kidney disease and type 2 diabetes is pretty immense. It averages about 50%. As you can see from the slide, there's multiple studies from different parts of the world and globally. And if you omit this gray line, this is patients with no chronic kidney disease. And if you combine all those with chronic kidney disease, from decreased eGFR to increase albuminuria, or a combination of all, you would come to the same conclusion that half of patients with type 2 diabetes do have diabetic kidney disease. And this data come from the NHANES up to 2014. And as you can see over the years, both the incidence and prevalence of end-stage kidney disease is on the rise. Of course, the prevalence is much higher because those patients are being cared for very well, that they do survive. And therefore, the actual number of patients with end-stage renal disease approximate to 700,000 in 2014. And I'm sure the numbers now probably approaching 1 million. And if you look at the causes of chronic kidney disease, you will come to this slide, which shows diabetes by far accounting for the most in terms of chronic kidney disease, followed by hypertension. And between the two, 2/3 of cause of end-stage renal disease are caused by either diabetes or hypertension. And therefore, this is an important opportunity to reduce the incidence of end-stage renal disease by addressing those two diseases alone. And as this slide shows, diabetes and hypertension are the most important cause of kidney failure, and over the year it's been going up. And so we really need to do something about it in order to reduce the morbidity and also the mortality and the cost of this disease in patients with diabetes. This slide shows the mortality, 10-year mortality in type 2 diabetes by their CKD manifestation. So if you compare patients with albuminuria to those with no kidney disease, you'd find that patients with albuminuria have 4 times the standardized incidence of mortality. When you compare patients with impaired eGFR, that incidence rises to 24%. And if you combine the both albuminuria and decreased eGFR, the incidence goes to almost half. This compares to no kidney disease about 11 times higher in patients with albuminuria and impaired eGFR compared to patients with no kidney disease. So it is imperative that we really address patients with albuminuria and impaired eGFR, trying to reduce their mortality. And of course, there are two important factors that drive the prevalence, that drive the all-cause mortality risk in those patients with diabetes. One is the eGFR, and that's the lower, the higher the mortality. And in red is patients with diabetes, and blue patients without diabetes. And not surprisingly, patients with diabetes have an increased mortality when eGFR goes down. Similarly, when you look at the same patients with albuminuria, the higher the albuminuria, the higher the mortality. And so really, this is an opportunity for us to try to reduce the mortality by identifying those two biomarkers, decrease eGFR and increase albuminuria. These are good biomarkers that will actually allow us to identify patients who are at risk of increased death and try to intervene in a timely manner. Not only that, but low GFR and increased albuminuria is also an independently increased patient cardiovascular mortality. Not only all-time mortality, but cardiovascular mortality. As we have seen in the previous talks, the cardiovascular mortality is increasing in patients with chronic kidney disease. So we've all been taught, and we've seen in the standard of care for those patients with diabetes, that the current treatment options are listed here. Intensive glycemic control has been shown in multiple landmark studies such as the DCCT in type 1 and UKPDS in type 2 to reduce microvascular complications, including chronic kidney disease. And so the target should be less than 7 unless there is contraindication and increased risk to the patient from hypoglycemia. Over the last 20 years, renin-angiotensin system therapy with ACE or ARBs have been a standard of care to reduce the progression of chronic kidney disease in those patients. And so we aim to lower blood pressure to target less than 130/80 if possible and safe. Similarly, we need to advise patients to reduce their protein intake and salt intake as well and avoid nephrotoxic drugs. And this has been the case since those landmark studies, the renal and IDNT. And as you can see, losartan and irbesartan reduces the incidence of doubling of serum creatinine in the stage renal disease or death. And because of this, we all now use those agents in patients with type 2 diabetes, whether they have high blood pressure or albuminuria or decreased eGFR. So what have we learned over the last 5 or 6 years from cardiovascular outcome studies? As you know, that those cardiovascular outcome studies were mandated by the FDA to make sure that all new anti-diabetic agents are safe from a cardiovascular point of view in patients with type 2 diabetes. And we've seen actually the importance of SGLT2 inhibitors for reduction of those cardiovascular outcome, for the reduction of cardiovascular diseases in those patients. However, this reached inflection point and a landmark time in the history of kidney disease. And in fact, this is the EMPIRIC Renal was published in 2016, just over 4 years ago. And what did we see in this study? We saw significant reduction in the incidence or worsening from nephropathy in those patients in that study by about 39%. This is unprecedented in the history of patients with chronic kidney disease to be able to reduce it that much. As we've seen, a blockage of the renin-angiotensin system did not reach that significant level. Not only that, but in this study also, whatever way you look at eGFR, the death from kidney disease in type 2 diabetes within the stage renal disease there was reduced in all those categories of eGFR. Just to show you that when you start SGLT2 inhibitor, you find an immediate reduction of albuminuria, and that is sustained throughout the study of about 4 years. Now, this applies both to microalbuminuria and to macroalbuminuria. Both of them are reduced concomitantly with SGLT2 inhibitor, and this reduction is sustained throughout the study period. And if you look at the safety of those, and remember, in the past, all medication used to reduce the progression of kidney disease, whether it's ARBs, whether ACE, whether mineralocorticoid receptor blockers, all of them have side effects in the form of hyperkalemia or acute kidney failure. However, in the study with SGLT inhibitor and empagliflozin in particular, we see no evidence of an increase in hyperkalemia or acute kidney failure. In fact, there was a reduction in that, albeit it was not significant. When you look at patients in the category of more than 60 ml per liter, you actually, and between 45 and 60 ml per minute, you will see that there is a reduction actually in those two important points of acute kidney failure and hyperkalemia. Following that, we had a number of cardiovascular outcome trials available, and as you can see, most of them actually reproduce the same result, which is there is a significant reduction in hard endpoint and soft endpoints of chronic kidney disease. So if you look at the CANVAS program and DECLARE program, there is something like 47% reduction, albeit here it was not significant. In the DECLARE study, there was a 47% reduction, but that was statistically significant. Of course, Vertis have been disappointed in all parameters that have been looked at, whether it was cardiovascular outcomes or chronic kidney disease. Now, this has been mentioned earlier. This is a heart failure study using empagliflozin, Impero-reduced, and in this study, there was a reduction in cardiovascular death or heart failure hospitalization. However, exploratory endpoint in the composite renal outcome was also significantly reduced. As you can see here, and this has been shown in the previous talk, there was a 50% reduction in end-stage renal disease or sustained profound decrease in eGFR. And if you look at this result, whether there was a prevalent chronic kidney disease or there was no chronic kidney disease, you arrive more or less at the same conclusion that there is significant reduction in the composite kidney outcome. So if you look at these in two ways, whether a patient have kidney disease or not, and whether the patient have recurrent heart failure or not, the result is the same. There was basically a reduction in those endpoints. I'm sure this was already alluded to. So the SGLT2 inhibitor have been really pretty useful, and the pathophysiology of this remains to be fully elucidated. However, definitely there is a decrease in intraglomerular pressure, decrease in blood pressure, arterial stiffness, and of course, because of the diuretic effect, there is a reduction in volume. As we've seen, there is reduction in albuminuria as well as oxidative stress. Now, I just want to remind you of the new classification of chronic kidney disease, and here that they use both eGFR and albuminuria, and basically when you add the two, you actually increase your risk. And when you have an increasing in the amount of albuminuria, you increase your risk. When you have a decrease in GFR, you have increased risk, and we have the two together, your risk dramatically increases. And as you can see in this slide, all those cardiovascular outcome studies actually looked at patients in the green category, which is the mild, either mildly decreased eGFR and albuminuria that is in the normal range. And so it is extremely important, therefore, to look at patients who have a more advanced chronic kidney disease status. And here we have really dedicated chronic kidney disease trials and heart failure trials, and that have come from those studies of cardiovascular outcome trials, which are not dedicated trials. So in these trials, the patients all have chronic kidney disease or have heart failure, patients with heart failure. And as you can see here, we have a credence, which is canagliflozin, dapagliflozin, and SCORED, which I'll talk about, this is sotagliflozin that was published only last month. And we're awaiting the result of IMPA-KIDNEY trial. In the heart failure trial, we have DAPA heart failure and Emperor reduce, which has been presented in the previous study. We're, of course, looking forward to the Emperor preserved trials to see whether those drugs also reduce cardiovascular endpoint in patients with the preserved heart failure. So this is the first study, which is the credence study, canagliflozin. And as you can see, it is a study that looked only in patients with diabetes. And as you can see, it's either reduced eGFR or albuminuria, macroalbuminuria with albumin creatinine more than 3,000, and basically on standard of care patients and a standard of care therapy. And these are the primary endpoint. And from a study to study, the primary endpoint is slightly different, but they're more or less, have this uniform and across the studies in the stage renal disease, doubling serum creatinine, and renal or cardiovascular death. And this slide summarizes the result of that study. In the primary composite endpoint, you can see a reduction of 30%. If you look at end-stage renal disease, there's a reduction of about 32%. If you look at dialysis, kidney transplantation or death, again, there's a reduction of nearly 30%. And if you look at cardiovascular death or hospital for heart failure, that's also reduced by 31% with a statistically significant result. The other study that looked at CKD is DAPA CKD, and again, similar, more or less similar study, except they looked at patients with and without type 2 diabetes. And again, you're talking about patients with reduced eGFR and with increased albumin and with reduced albumin secretion. And again, if you look at the result, more or less you can almost superimposable. So if you look at the primary composite endpoint, here you have a reduction of about 39%. You look at just the kidney outcome, which is basically eGFR reduction, end-stage renal disease or kidney death, there's a reduction of about 44%. When you look at cardiovascular data, that's cardiovascular death or heart failure, there's again a reduction of 29%. When you look at all-cause mortality, there is a reduction of about 31%. So those studies obviously reaffirmed, number one, that those drugs are protective in kidney disease, but not only in those patients with more or less normal kidney function, but in patients with decreased kidney function. And basically this summarizes what I have been talking about earlier. If you look at the composite kidney cardiovascular outcome, cardiovascular and all-cause mortality, they all have been positive with the exception of credence and all-cause mortality. So This table illustrates the slight differences in the three, and here the last one is the impact kidney that we are awaiting the result of between those three. All of them look at, of course, chronic kidney disease and diabetic. The difference is that Credence does not have patients without diabetes and does not have patients with albuminuria. The DAPA have patients with and without diabetes and albuminuria, and the EMPA has all, and they have patients without albuminuria. Why do we have that category of patient? Is because of the following I will come to. So this is again basically inclusion criteria, which is similar to the previous study. However, here we're looking at again kidney disease progression and in the primary cardiorenal composite outcome. Now, the reason we want to look at that is, and I believe that I have mixed a slide here, is because of the fact that many patients, about a third of patients with chronic kidney disease, do not have actually greatly increased albuminuria. The last study that was published just last month is sotagliflozin in patients with chronic kidney disease. And if you remember, this drug has been studied in type 1 diabetes, which to their disappointment, although it was positive, it has not been approved for use in type 1 diabetes by the FDA. And as you can see, in fact, the outcome they look at is not chronic kidney disease. They looked at cardiovascular outcome in the form of death from cardiovascular disease and hospitalization for heart failure, which was positive. I was hoping that when they looked at chronic kidney disease, you will have the actual result and the result of kidney failure. However, it is important to emphasize that patients with chronic kidney disease do die from cardiovascular disease, and use of SGLT2 inhibitor reduces the actual death from cardiovascular disease. So now, therefore, we have patients not only in the low risk category, but in the greater risk category in patients with chronic kidney disease, that is with decreased EGFR and increased albumin secretion. So in the last few slides, and I hope I will be on time here, I will summarize the fact that these drugs are obviously coming on top of standard therapy, such as RAS blockade, and therefore they will be adding beneficial benefits to those category of patients that continue to die from their chronic kidney disease. So let me summarize what I have just presented. Chronic kidney disease is common in type 2 diabetes, more common than what we think, and it's responsible for majority of cases in this stage renal disease. Patients with chronic kidney disease on standard care of therapy continue to die from this complication. SGLT2 inhibitor slows the progression of kidney disease and reduces the cardiovascular death in patients with and without diabetes mellitus and chronic kidney disease. And these drugs should be part of the pharmacological treatment of patients with chronic kidney disease, and of course, as we have seen in the standard of care for diabetes, with also cardiovascular disease. And with that, I'd like to thank you for your attention. I would be happy to answer any questions.
Thank you, Dr. Mahfouz, for this excellent presentation about the potential role of selective glucose transporter in the management of chronic kidney disease. We will receive question for the two speakers, Kamal, Prof. Abdulrauf Mahfouz. So just submit it in the Q&A icon. Dr. Mahfouz, there is one question here. I don't know, 54-year type 2 diabetes, hypertension, lipidemia, and smoker body mass index. He will go for dental implant. And they want tight hemoglobin A1C below 6. They don't mention the baseline, actually, hemoglobin A1C. So
can you just repeat? I'm sorry, can you repeat the question? Because I had a problem with sound.
He mentioned a patient, 54-year-old, type 2 diabetes, hypertension, lipidemia, non-smoker by the 25, he's going for dental implant. And they want tight control before he go to dental implant. Okay, he want to reduce hemoglobin A1C below 6, but he didn't mention what's the baseline or the current hemoglobin A1C now. So we cannot do any comment about this. So he's asking if he can use metformin and selective glucose transporter in the management temporary. Really, the use of the medication depends, of course, on how far from the target. So we don't mention the target hemoglobin A1C. So if you are 1.5% or less from the target, maybe use combination oral agent. So we need more detail to answer this question. Dr. Mahfoud, what's the lower limit of the estimated glomerular filtration rate we can use empagliflozin or empagliflozin?
Okay, so as we've seen there, with SGLT2 inhibitors work best to reduce glucose when the EGFR is the normal range. The lower the EGFR, the lower the efficacy of SGLT inhibitors. So if your aim and objective is to reduce blood sugar only, then obviously you're going to use it when the EGFR is more than 45. When the EGFR goes below 45, your efficacy goes down. That is really not well. However, if your objective is to reduce cardiovascular events or to reduce progression of chronic kidney disease, then you can go as low as the study mentions. So those studies that have been looked at actually have gone down to as low as 25 ml per minute. However, as I mentioned earlier, the SGLT2 inhibitor work as low as EGFR of 30. So it really depends on what is your objective. For protection, cardiovascular renal protection, you can use them, of course, with an EGFR more than 30. But if you want them for glycemic control, you'd be better off using them when the EGFR more than 45.
So we will stop it below 45. Excellent. Any studies they use it in type 1 diabetes for halting the progression of chronic kidney disease?
I'm sorry, there's a lot of noise, maybe the paper or whatever.
Any study did they use selective glucose transporter inhibitors in type 1 diabetes and chronic kidney disease in type 1 diabetes?
Yes. Yeah. So in type 1 diabetes, they only have used all those studies, all drugs, whether sotagliflozin, EMPA, or DAPA, they looked at glycemic control only. They have never yet been looked at in patients with complications such as albuminuria, chronic kidney disease, or heart, or cardiomyopathy or heart failure in type 1 diabetes. They have not been looked at there. But I'm not sure if there are studies that are looking at that, but it would be interesting to look at.
Prof. Kamal, what we learn from the embroider study, reduced study? I know that you are aware any study that they look for use of selective glucose transporter inhibitor in patients with normal ejection fraction in diastolic heart failure, for example, or only the study showed benefit in patients with
yeah, thank you, Mr. Chairman. No, actually, EMPEROR reduced and APHF looks at ejection fraction less than 40. Ongoing right now, we have EMPEROR preserved and we have the liver. Both of them look as SGLT2 inhibitor in patients with preserved ejection fraction, or what we used to call, as we say, diastolic ejection fraction, diastolic dysfunction. We're expecting the next year to declare the results. Hopefully, we really need a positive trial because we don't have anything to serve this group of patients except controlling risk factors. And these are really, really difficult patients to treat because of the very small capacity of volume tolerance. They go into volume overload in no time, and they keep going and coming, unfortunately.
Excellent. So what's your experience in using empagliflozin or selective glucose transporter inhibitor with diuretic? Is there any risk of hypotension or any risk of increased urea creatinine if you combine ready patient with heart failure, most of them with reduced ejection fraction, they are on diuretics. So if you add, for example, selective glucose transporter, any risk of hypotension or?
No, actually, because we are dealing with a borderline blood pressure most of the time, we tend to pull the loop diuretic gradually when we introduce ARNI and SGLT2 inhibitor. So we are really more and more of less and less of loop diuretic. Sometimes we see second opinion patients with hypertension or with postural hypertension, and unfortunately, they did not decrease their diuretic. And once we just hold it off for a few days or keep it on an intermittent days dose, the hypertension part and the dizziness part improve. Now, for the renal function, it's quite a challenge because we don't know. Is it an impairment due to the congestion of the kidneys with generalized edema that patients have with heart failure, or is it a cardiorenal part, or is it a true renal injury from the diabetes if there is a diabetes? But for sure, any creatinine that we experience that increase when we offload our patients comes down back to its baseline part. And for the heart failure with estimated GFR 20 and above, we don't have a problem. We start the SGLT2 inhibitor for the sake of heart failure part. I totally agree with Dr. Abdurrauf about the efficacy on glycemic control, but we are really not the one to talk about that. But we do have the evidence of improvement of quality of life outcomes for looking at heart failure per se.
Excellent. So, Dr. Kamal, what's your recommendation now regarding the use of selective glucose transporter inhibitor in heart failure? So, what do you recommend for the audience?
Okay. We heart failure experts, we don't have a definition called stable heart failure. We have to use all the guns, and we keep up titration, and it's the biggest challenge. So right now at our center, heart failure program, we prescribe SGLT2 inhibitor for every patient who can get it, either from the hospital or buy it, who has a GFR for more than 20 or 30, and who has already been on the guideline-directed medication, which is basically all our patients. It's a very, very effective drug, extremely effective drug, especially for those group of patients who have blood pressure less than 95. We can only give them SGLT2 inhibitor. I know it was from the exclusion criteria, but we have the ability to do that and closely follow up our patients. Very good drug to use in the right patients.
Excellent. Dr. Kamal, Dr. Raouf, he's using cutoff point of estimated glomerular filtration rate 45. Cardiologists, they are very aggressive, or because of the study?
Yeah, because of the study. Because of the study, because nothing else. And with the blessing of our nephrologist, by the way.
You use it up to 20. You can use it up to
20 means
pressure rate up to 20. You can use.
Yeah, because the emperor reduced had a cut point of eGFR of 20 and above, so we use it.
Okay, thank you very much. Dr. Mahfouz, any recommendation regarding the management, the use of selective glucose transporter 2 inhibitors in the management of a chronic kidney disease? What's your recommendation?
Yeah, so let me just a couple of points about the diuretics as well. If you look at the empiric trials, the original, the first one, 40% of the patients were on diuretics to start with. By the end of the study, 60% were on diuretics. So obviously, you can use them and you can add them as well as you go along, of course, individualizing therapy. Again, with CKD, you saw the results. Not only can you use them, but you don't get into problems of side effects like you do with other medications that are standard of care, such as ACE or let's say aldactone, for example, with hyperkalemia, volume depletion. Volume depletion has not been a major issue with the SGLT2 inhibitor, unlike, for example, loop diuretics. So they are actually mild. And the reason you get that benefit, etc., it's not because of only diuretic effect. There are so many effects that SGLT2 inhibitor that are responsible for the benefits. And that's probably why you don't get into that problem, and because of their mechanism of action as well. So I think we're going to see those medication used more frequently, and we're going to see the guidelines changing. In fact, the guidelines can't catch up with the result of those studies. As soon as they publish a guideline, another study comes to give you more positive result in those. So no, those group have gone from just a glycemia to a cardiology medication to a nephrology medication. And in fact, in no time, you're going to see the reverse role of those drugs. They are going to be a cardiology medication, a nephrology medication, and a glycemia medication. So of course, we're going to use them for glycemia for patients who are, only have issues with the glycemia.
Dr. Mahfoud, do you think you can use this chronic kidney disease due to other disease like glomerulonephritis due to hypertension, not diabetes? Do you think, like heart failure, you can use it, some medication use it without diabetes? So we can use it in a chronic kidney disease regardless of the
So DAPA-CKD used patients with diabetes and patients without diabetes, almost, I can't remember the ratio, but a good consistent ratio. And both groups, whether they have diabetes or they don't, benefited equally. And the IMPA kidney that is going to be, published, hopefully not in the near future, is going to look at the same kind of questions, which is, can they benefit patients without diabetes? And they are included. In patients also with decreased EGFR, albuminuric, and non-albuminuric. So we're going to get a lot of data as well. And that's what I said, these group of drugs is going to be, they're going to be taken by other people from us. But of course, we're going to be using them well.
Very good. So is my voice clear, or do you hear me very well?
Yeah, sometimes at the paper, it looks like there's a paper there.
Do you hear me very well? So now we'll stop here and we'll go for the last part of today's activities. So we'll go for the next presentation so we can finish early, maybe 10 minutes earlier. Thank you, Prof. Kamal. Thank you, Prof. Mahfoud. Thank you, Saudi Heart Association and Bohingers for this excellent presentation. Thank you, all audience. Now we'll have the third and the last part of our today activity. It is so interesting, so keep up with us till the end. We'll finish almost even before 5, maybe 4:45. So the next speaker will talk about practical guidance in selective glucose transporter. We will talk about proper use. My colleague will be Dr. Abdul Wahab Bawahab. He is consultant endocrinologist, Saudi General Hospital. He is famous and well-known, presenting locally and regionally. Welcome, Dr. Bawahab. Do you hear me, Dr. Bawahab? Dr. Saeed, you want to present? Wahab, Saeed, you want to start?
Hello.
Dr. Saeed, do you hear me?
Yes, I hear you.
So now we'll introduce Dr. Saeed Khadr. He's fellow of Royal College of Physicians, UK. He's consultant physician and endocrinologist, Al Habib Medical Group, Al Ulayya, Riyadh. If you want to start now, till Dr. Bawahab prepare his presentation.
Okay.
The floor.
Thank you very much, Dr. Nasser. Do you hear me, Dr. Nasser? Hello? Okay.
Yes, it is clear.
Dr. Nasser, for this nice introduction. I'm going to present a case, which is a case of peripheral arterial disease. This is a lady called Fatima. She's 57-year-old female with rheumatoid arthritis and type 2 diabetes for 2 years. She presented to the clinic with pain in her legs. Unfortunately, a lot of us as physicians and diabetologists, sometimes we ignore these symptoms and we always refer to painful diabetic peripheral neuropathy, and we forgot that there are other causes of pain in her legs. And the patient, she believes that her leg is painful because of her rheumatoid arthritis. It's very, very important to take a history from those patients when they presented to the clinic. What sort of pain? And she said that this pain in her right leg, especially when walking and climbing stairs, more prominent on the right side. She believes that this is due to arthritis. So this is the patient belief. As a physician, we have to take more history, what type of pain, and what are the precipitating and releasing factor. She has type 2 diabetes for 2 years, and we know diabetes, even if she's been diagnosed 2 years ago, probably she's been diabetic for longer than that without symptoms. She also has other cardiovascular disease risk like hyperlipidemia, hypertension, and she is ex-smoker, and she's been a smoker, heavily smokes more than 30 cigarettes per day. And she has rheumatoid arthritis. She's on a statin, she's on ACE, and she's on methotrexate and metformin. So it's very important to remember that type 2 diabetes, 50% they are asymptomatic, and sometimes we are very late in making diagnosis. And when you look at the patient, she looks well and comfortable, cardiovascular respiratory system examination normal. She is overweight with BMI 27, and her blood pressure is still above the target. So it's important what sort of pain. So you have to listen to the patient that the pain started after walking for approximately 100 meters. Where is the pain? The pain in the calf, and it might radiate up the whole leg. And also she said, when I go upstairs, and the cramp disappear when she rests. So it's very important to speak about what is the precipitating factor. It's exercise or walking or a climbing stair, and disappear completely after rest for a few minutes. This is intermittent claudication rather than pain from her arthritis or neuropathy. Also, at the same time, because she is diabetic, she might have other symptoms, other complications. She said, I have numbness, pins and needles in her leg. So we have not to ignore it. Physical examination is important. As diabetologists, I usually start examination from toes up to head, because we must always, at any time, to examine peripheral pulses, which unfortunately, a lot of us, sometimes we don't examine feet. Very important to examine feet even before we examine the heart. And she has, normal sensation, but this doesn't exclude that she has neuropathy. Musculoskeletal examination is normal. She has palpable femoral pulses with no bruit, that's fine, but she has weak popliteal pulses and absent pulses, dorsalis pedis and anterior tibialis. And the ankle brachial index is 0.8. Anything less than 0.9 indicate peripheral arterial disease. This is her chemistry. Her A1C is okay, suboptimal. Some may consider it is fine, but to me, as she's 57 with a lot of cardiovascular disease risk factor, probably for me the target to be less than 7 or around 6.5. Her LDL, HDL is fine, triglyceride is okay, total cholesterol, and she has good kidney function, and she has an element. Probably she might have nephropathy as well, as her urine albumin creatinine ratio is high. So the question is, what's this pain? Is it part of her rheumatoid arthritis, peripheral arterial disease, or peripheral neuropathy? As I said, intermittent. This is intermittent claudication, pain in her calf with absent pulses, dorsalis pedis, anterior tibialis, and weak popliteal pulses. We should make the diagnosis as early as possible. The ankle brachial index is less than 0.9. This is enough to make a diagnosis of peripheral arterial disease, and think of either do more investigation or refer to your colleague, the vascular surgeon. Usually, this is just a slide. The clinical presentation usually of peripheral arterial disease, unfortunately, we are very late in making a diagnosis. We don't need to find a leg like this, acute ischemia or already ischemic leg. We need to make the diagnosis before. It could be asymptomatic. So that's why it's a must for any physician, diabetologist, always, at least every 6 months or a year. And on those with the newly diagnosed, to check pulses, always check pulses, which takes few minutes, anterior tibialis, dorsalis pedis, popliteal pulses, etc. But please examine the feet. And it could be, sometimes they come with intermittent claudication. This is too late. We should make the diagnosis before that, before we reach intermittent claudication or before we have the pain at rest, or what we call the critical limb ischemia, rest pain, ulceration, necrosis, gangrene, and sometimes they're presented with acute limb ischemia, which is the worst thing to have, and sometimes it's difficult to save the foot or to save the leg. We might need amputation. The independent risk factors, peripheral arterial disease, diabetes. So if somebody has diabetes, there is 4 times the risk of patients who doesn't have diabetes. Smoking, 2.5, hypertension, and total cholesterol is not that important problem. It's important, but it's not that significant as a risk of having peripheral disease. So diabetes first, smoking and hypertension, mainly diabetes. And we should put this in our mind that we should examine, as we examine heart, we examine eyes, we look at the patient to look at his feet and examine for peripheral pulses. The management, how do we manage this patient? The patient already in your clinic. After we examining her, we make the diagnosis that she has peripheral artery disease. Peripheral artery disease is not just peripheral artery. This is an indicator of macrovascular complication, and probably she has generalized atherosclerosis, and she is at very high risk of having cardiovascular event, either MI or a stroke. She might have carotid bruit, or, she might have generalized atherosclerosis. Patient, this is again the natural history. What's the intermittent claudication? You have to remember, especially in elderly. Some of them, they have only 5% they have intermittent claudication. When it comes to those with intermittent claudication, they might worsen, just have more and more pain until they have ischemia. And 7% they have lower extremity bypass surgery, and 4% they might have amputation. What other cardiovascular morbidity and mortality with those with peripheral artery disease? Not only just to save the leg. Look here, 5 years, the mortality is high, 30%. 70 of them, 75% of them will have cardiovascular event, okay? And non-fatal event by 20%. So it's important, very, very important. This is an indicator that we are dealing with generalized atherosclerosis. So you suspect peripheral arterial disease. What are your immediate recommendations for Fatima? Which I'm sure all of you will know that we should refer to a vascular surgeon immediately. What else would you do for Fatima? What else? Is it to reinforce the importance of smoking? She's already ex-smoker, so we should advise her not to smoke at all. Blood pressure, we have to lower it. And it's very important to the lipid lowering, she's okay. Assess Fatima diet and exercise. What do you do? All of these things. So we need to even improve her blood sugar, blood pressure, cholesterol, and it's very, very important also to enhance or encourage the exercise. But she has intermittent claudication, so it's important to ask her to walk as much as she can, but at the same time, we need to consider maybe aspirin and Plavix. I'll come to that. So Fatima returns 6 weeks later following her annual diabetic foot assessment, and she has unfortunately ulcer. So if we don't save the foot quickly, this lady, as we said in the previous slide, the natural history of peripheral arterial disease starts with intermittent claudication, then they end with ulcer or gangrene. Especially she has also peripheral neuropathy. So she might have an neuroischemic ulcer, which is very difficult to treat. So the vascular surgeon, when we refer usually to vascular surgeon, they would do a lot of tests, a lot of investigation. It's an obligatory to start aspirin. And sometimes nowadays we start also Plavix, very important, until they do further surgical intervention, which is usually they might consider either lower limb angioplasty or sometimes bypass, depending on the results of the investigation, the angiogram, etc. So this lady, she has been experiencing pain in the right leg, okay, and big toe as we said for 3 weeks. So she had an ulcer, and she should be seen by podiatrists, but we should emphasize that a vascular surgeon should be involved. She has type 2 diabetes, peripheral arterial disease, hyperlipidemia, hypertension, rheumatoid arthritis. I need to save the lower extremity as much as we can. At the same time, I need to probably do more and more investigation to be sure that she doesn't have coronary artery disease or carotid artery disease at the same time. So aspirin should be added immediately. The other observation also, patients looks when she came healthy, but at the same time, still the blood pressure is better, which is okay. But with the food examination, again, is very, very important to assess the food. If you don't know how to assess the food, especially the ulcer, we have to look at the depth, at the size, if it is gangrenous, if it is infected, not infected, and probably the podiatrist or food clinic is very important. Here, her blood test, unfortunately, her A1C deteriorate rather than improving. So it's important to probably consider something else. We'll come to that, to improve her HbA1c. And these days now, the recent guidelines, we have to consider the drug that's been approved by the FDA, for example, Saudi FDA or US FDA, etc. At the same time, there is any benefit to stop the cardiovascular event. I need something cardioprotective, nephroprotective drug, the anti-hyperglycemia, because of the revolution of the new medication like SGLT2 inhibitor and GLP-1 receptor agonist. It's a must. If somebody has an established cardiovascular disease like this lady, she's already having peripheral arterial disease, we should consider the new medication. It's a must. So what are the management considerations as a physician? Please select all that apply. Peripheral arterial disease affects 1 in 3 people with diabetes over the age of 50, or presence of peripheral arterial disease is an independent predictor of cardiovascular event. Up to 50% of people with peripheral arterial disease may have no symptoms. Smoking is a risk factor. Patients with BAD are more likely to have generalized atherosclerosis. If gangrene occurs, amputation is required to prevent sepsis, not always. BAD can affect the carotid, renal, etc. As we said, generalized atherosclerosis. The 5-year mortality rate for patients with intermittent claudication, I mentioned in the previous slide, up to 30%. So all of these we should look at them and we should remember. So intensive cardiovascular risk factor here, modification is very, very important for me as a physician, and probably the surgeon. We should consider either angioplasty or bypass. A lot of patients, they just need aspirin or Plavix, plus modification or improvement of her glycemic control, hypertension, stop smoking, and to some extent, to lower extent, also the cholesterol. Very important to improve the cholesterol, not only to save the lower extremity, also to prevent cardiovascular event like MI or stroke. The other things here, what are your next steps for Fatima? Immediate ulcer treatment, and if you can see, or alert the vascular surgeon. Very important to cooperate with your colleague, the vascular surgeon. Assess Fatima cardiovascular vascular complications. You might need cardiac CT, for example, which is very important. You might need to do probably Doppler of her carotid, etc. Are we going to add DPP-4 inhibitor? Why to add it? There is no cardiovascular benefit, but certainly we have to consider, as I said, the new medication with a benefit to the cardiovascular. It's very, very important, which is available, and it's the revolution in treating type 2 diabetes, because we are not hyperglycemia concentric now. We concentrate to prevent. Our job is to prevent the cardiovascular event. So this is what we have to do. Immediate ulcer, we should treat ulcer as much as we can, might need admission. Vascular surgeon should be involved, probably do culture, antibiotics, etc. But alert the vascular surgeon. The DDP4, I will not do it. We'll consider here, I will not consider DDP4 inhibitor, because we are dealing with a lady with an established atherosclerosis cardiovascular disease. So here we should optimize, as we said, cardiovascular risk reduction. How? Which medication? Sulfonylurea, of course not. Insulin, not. The only things now is either SGLT2 inhibitor or GLP-1 receptor agonist. Important to improve her lipid profile, yes, although it's not that the cause of her peripheral arterial disease, but this is to prevent cardiovascular event like MI, stroke, etc. So in patients with symptomatic peripheral arterial disease, single antiplatelet therapy is recommended, and you can look here, probably if you know or not, but at least we have to consider here oral anticoagulation. At least as a physician, we should consider aspirin or Plavix. and sometimes you consider Plavix, but at the same time, you have to discuss with your colleague, the vascular surgeon. So very, very important. Those with symptoms, okay, it's important. Here, if they are asymptomatic, no aspirin, we should, but it's important to consider aspirin or Plavix and refer to a vascular surgeon. Again, here regarding the European Society Cardiology guidelines on diagnosis and the treatment of peripheral arterial disease, as we said, it's important for me as a physician to improve the blood sugar, blood pressure, dyslipidemia, stop smoking, encourage exercise. But at the same time, we have to say what's next, what sort of things, which is very important here, that it is suggested here, evidence or general agreement, this is the class, but it's important to consider antiplatelets, very, very important. It is important, as we said, to improve the blood pressure, okay? What sort of medication? There is a lot of medication. Usually in diabetic patients, we have to consider ACE and ARB because we know they are nephroprotective, and that lady, she has high urinary albumin-creatinine ratio. It's important. At the same time, if somebody is a smoker, we have to stop smoking immediately. Diet and physical exercise, we always speak to the patient. Statin is important, not to decrease or to prevent peripheral arterial disease also, but because she has generalized atherosclerosis, I need to prevent all cardiovascular event, and we have to achieve the target of LDL cholesterol to be less than 70, and even if it is lower, will be better. The lower is better regarding LDL cholesterol. If she couldn't tolerate statin, we have to consider PCSK9 inhibitor. Very important. We have to do all the things to lower the cholesterol, lower blood pressure, and improve her glycemia. Probably HbA1c, as I mentioned, 7%, but in this case, why not to decrease it to be around 6.5 without hypoglycemia? Especially we have a lot of medication now, GLP-1 receptor or SGLT2 inhibitor. They are insulin independent. At the same time, will never ever cause hypoglycemia. So we should consider it rather than go to other anti-hyperglycemia. Antiplatelet is recommended. Okay, so here the patients with type 2 and BAD are at increased risk of foot ulcer. We have to prevent foot ulcer as much as we can. Podiatrist is important. Even choosing the right shoes is important. At the same time here, measuring the ankle brachial index is very, very important. If you don't do it, this is probably to refer to the vascular surgeon where they do a lot of tests. Here the question which is important, would you have considered adding SGLT2 inhibitor or GLP-1 receptor agonist earlier in the management of this patient? Even it's not too late to consider this medication. Very, very important. As we know, any guidelines now, the guidelines, the European guidelines, the ADA guidelines, they said immediately anybody with established atherosclerosis cardiovascular disease, we should consider GLP-1 receptor agonist, and we know the leader study and many studies, and SGLT2 inhibitor. You have to discuss with the patient. If there is heart failure, we should immediately consider SGLT2 inhibitor. If there is no heart failure, either GLP-1 receptor agonist or SGLT2 inhibitor, independent of HbA1c. Whatever the HbA1c, we are not looking at HbA1c. We are treating a lady to prevent the further atherosclerosis. So it doesn't matter if her HbA1c 6 or even 5, we should consider GLP-1 receptor or SGLT2 inhibitor. These are the guidelines, again, the ADA 2020, where they said among patients with type 2 diabetes who have established atherosclerosis cardiovascular disease. Peripheral arterial disease is an established atherosclerosis cardiovascular disease. It's not only MI or angina or stroke. No, peripheral arterial disease is an indicator of generalized atherosclerosis. Very serious. It means advanced atherosclerosis. Or indicator of high risk established kidney disease or heart failure, and SGLT2 inhibitor or GLP-1 receptor agonist demonstrated cardiovascular benefit. We need a clinical or evidence-based medicine. Which one is GLP-2 inhibitor to consider? Is there a study for IMBA or DABA or CANA? So you have in your clinic to say which guidelines, where is the evidence? Is there studies? And we know that the IMBA is one of the, a lot of studies, the IMBA study, And Emperor study showed that there is significant reduction when we use IMBA in treating type 2 diabetes with an established atherosclerosis cardiovascular disease by significant reduction of the MACE, the 3B MACE. And we know also it decreases chronic or at least deterioration in the diabetic kidney disease. It is a nephroprotective. And I said here, independent of HbA1c. Don't look at the HbA1c. It's very important. The HbA1c is 6. Don't say this is fine. We have to consider it. You are worried about hypoglycemia. If she is on sulfonylurea, stop sulfonylurea and give SGLT2 inhibitor. If she is on insulin, decrease or lower. You might stop it, but decrease the insulin and consider these medications. It's a must because this is the only medication, GLP-1 or SGLT2 inhibitor, that will benefit this patient with an established atherosclerosis cardiovascular disease. And if you look at this, it's a busy slide, but certainly you know all these things, the metformin, SGLT2 inhibitor, GLP-1 receptor. DDP4 inhibitor, it's a good anti-hyperglycemia, it is safe. It's not going to have any cardiovascular benefit. GLP-1 receptor agonist, yes, it is good, especially in patients who are obese and patients with angina. From the LEADER study, we know at least that liraglutide is very effective, okay, and there is other studies. But certainly, SGLT2 inhibitor is very important. The efficacy is intermediate, will lower the HbA1c around 1, sometimes up to 2%, but there is benefit in those with established atherosclerosis, cardiovascular disease, primary and secondary, especially the secondary, as this lady, IMBA and CANA, okay, benefit for the heart failure, anyone, IMBA, CANA, and DABA, but you cannot, if there is no studies on DABA, declare a study more primary prevention, but it's not that significant. But here with established atherosclerosis cardiovascular disease, IMBA will be the #1, independent of HbA1c. Metformin is fine, but it didn't show any significant reduction, although in UKIPIDIS study, there is a slight benefit as cardiovascular benefit. So from this case, what we are going to learn, first of all, as I said, it's very important, and I probably ask myself and my colleagues, any physician, patient with diabetes, please start examination the foot. Don't forget the feet. It's very important to look at the foot or the feet, look at the color, look at the skin, touch the foot. Sometimes I put my hand inside the shoes, just in case if there is anything that might cause the ulcer. But it's important not only to examine the sensation, light touch, no, check the pulses, dorsalis pedis, anterior tibialis, go up, popliteal pulses, femoral. It's important. Listen with your stethoscope for a at least look at the color. You might look at the color, you might look at the bottom. Sometimes we have callus formation, which might indicate a lot of things, okay? So it's important. So, and at the same time, for us as physicians, we have to do all the management to prevent cardiovascular event. So if you find absent pulses or you diagnose peripheral arterial disease, consider this as an indicator of generalized atherosclerosis, and your patient, if you do anything, if you don't do anything, your patient will die soon with coronary artery disease or stroke, because it's not just lower extremity. This is an indicator that my patient have generalized atherosclerosis. Early diagnosis of peripheral artery disease is important. And as I said, a lot of patients, they have asymptomatic. We don't need to wait until the patient start to complain of intermittent claudication. Pain legs, a lot of causes, but at least check the pulses. It could be neuropathic pain, that's fine. It could be arthritis, it could be knee, it could be muscle cramp. It could be anything, but important to exclude peripheral arterial disease. Patients with PAD are at risk of foot ulcer. Very, very important. If you diagnose absent pulses, look at the foot. Immediately you have to check and ask the patient to see the podiatrist, okay, and keep an eye and see him probably every month. And probably you need to make some sort of diagnosis, investigation if you can. But if not, I will refer to vascular surgeon unless you have all the facility to do Doppler or do angiogram. And I'll stop here. Thank you very much.
Thank you, Dr. Saeed, for this excellent practical case presentation about peripheral vascular disease. Please keep up with us. So at the end, we'll have discussion. So we'll go to the next speaker. The next speaker is Dr. Rashid Al-Juwair. He is consultant endocrinologist and division head of endocrinology and diabetes at King Fahd Military and Medical Complex at Eastern Province. He will give also another interesting case presentation today. Welcome, Dr. Rashid.
So, Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Nasser, for your introductions. And my talk today will be on the use of SGLT2 inhibitors in primary care. We know that my colleagues, they have started on most of the topics, which I will speak in brief. The burden of cardiorenal metabolic diseases in patients with type 2 diabetes. We know that around 30 out of 4 people with type 2 diabetes, they are failing to achieve A1C below the targets. And most of them, around 73%, they are above the targets. So that's why there is a reduction in life expectancy of patients with type 2 diabetes, especially when started in a younger age group, around below 40s, or in the 40s. There is estimated reductions up to 8 years in life expectancy. What is the most common cause of this death in people with diabetes? Is it retinopathy? Is it nephropathy? Is it amputation or hypoglycemia? I think it's not. The most common cause is the ischemic heart diseases, or the heart in general, cardiac diseases in diabetes. This is the introduction to what we are going to talk about. Most of my colleagues talk about the importance of therapy of such patients. Diabetic patients, they are considered now as cardiovascular risk factors, and they are the same. They have the same cardiovascular risk as those with non-diabetes with prior myocardial infarction. This is here to show us that non-diabetics patients, they have low risk factors of cardiovascular diseases compared to diabetics without previous MI. They are similar to those with previous MI. They are non-diabetics. So it is a very high risk factors. These are the sorry, hello? Hello?
Continue, continue.
Yeah. Cardiovascular and kidney diseases are major contributors to the burden of type 2 diabetes. I think that was mentioned in the previous presentations with my colleagues. We know that approximately 1/3 of patients with type 2 has coronary vascular disease, and type 2 diabetes alone is associated with reduced life expectancy, as I mentioned before. There are also reductions in the estimated in the kidney and increase in the heart failure rates up to 67% of patients with heart failure. They have already chronic kidney diseases, diabetic patients. Chronic kidney disease also affects up to 40% of patients with type 2 diabetes. Now, we know that life expectancy, as I said before, is reduced in patients with diabetes, and especially if they have coronary vascular disease or chronic kidney diseases. Diabetes is associated with high risk of heart failure. There are approximately 3 out of 10 of people with diabetes, they have heart failure. 2 to 3% of patients developing heart failure each year. And patients with type 2 diabetes are 2.5 more likely to develop chronic heart failure than those without diabetes. Now, improving the patient's outcome with the use of SGLT inhibitors. There are a multifactorial management of cardiovascular risk factors. We know now not only measurements or treatments of glucose control, reaching the targets of A1C is the most important things in management of diabetic patients. There are other factors with other cardiovascular factors should be treated, like blood pressure, reduction of blood pressure below 130 to 80, reduction of the LDL cholesterol below 70 or below 50, even in high risk cardiovascular risk patients. Individualization of lifestyle, diet control is very essential also in the management of such patients. Cardiovascular risk factors are not a target in many patients with diabetes. As I said, The prevalence of meeting goal of cardiovascular risk reductions, you can see it here, as we said before, 42% only reaching the goal, the A1C goal, 29% reaching the blood pressure, you can see here, reaching the LDL goal in 49% in such study, in meta-analysis study, the HDL goal in 58% most of diabetic patients, and also even for the triglycerides. SGLT2 inhibitors have been shown to improve the cardiovascular risk factors in patients with type 2 diabetes. We can see that most of the giflozin groups are having a very good effects on reductions of A1C, and also they have effect on the weight and the systolic pressure and diastolic pressures. A reduction in the cardiovascular, heart failure, kidney outcome observed with the SGLT2 use in diabetic patients. We can see here the EMBA-REG outcome trials, the empagliflozin and the CANFOS program. There is reduction in the MACE up to 14%, and in the cardiovascular death rates up to 38% in the EMBA group. And we can see the heart failure reductions by 35%. In the CANFOS group, the 33% shows us. Or even the declared shows around 27% in the heart failure rates reduction. Kidney outcome also improved in SGLT2 inhibitors. You can see it by the EMBA groups, up to 39% reductions. Also the same for the CANA groups, and the DABA up to 47% reduction. What is the effect of SGLT2 inhibitors on the cardiorenal programs? Most of us know that it has a diuretic effect, it has glucose excretions, and prevent reabsorption of glucose, and natriuresis. By this mechanism, we can see that there is inhibition of sodium and hydrogen exchange receptors, reducing the afterload, reducing the preloads. That's why it improved the blood pressure, the kidney disease, deteriorations is improved, reduce the body weights, the A1C, and even the cardiovascular risk, death rates, and hospitalization for heart failure. Use of SGLT2, so guidelines and recommendation for SGLT2 inhibitors. I think also it was mentioned in the previous slides. I don't want to take a longer time in these slides. Since 2009 to 2015, it was used as only glycemic control to reduce the blood sugar by the ADA and the European diabetic associations. In 2016, cardiovascular and mortality benefits by the Canadian diabetic associations, they found that the empagliflozin shows a reduction in the risk of cardiovascular and all-case mortalities. By the 18th, benefits of atherosclerotic cardiovascular disease and chronic heart failure was observed also by the American Diabetic Associations. The empagliflozin and canagliflozin was recommended agents which proven as beneficial for the MACE and cardiovascular death. 2019 nephroprotections in type 2 diabetics, those with diabetic kidney diseases, it was found by the ACE and the European Society of Cardiology. They recommended the use of SGLT2 inhibitors with evidence for cardio and nephroprotections to reduce the progression of diabetic kidney diseases. So in 2020, this year's independent of A1C use, the atherosclerotic cardiovascular disease, the heart failure, and chronic kidney diseases predominates the use of such SGLT2 inhibitors. So it was recommended by most of the diabetic associations worldwide. Here, this is the program, the diagram. You can show us the 2019 and 2020 ADA standards of medical care in diabetes. They recommend the use after metformin and lifestyle modifications to classify the diabetic patients to atherosclerotic cardiovascular disease risk, high risk, or non-atherosclerotic cardiovascular disease risk. So those with high risk, they are preferring the GLP-1 receptor agonists if proven beneficial, and the SGLT2. Also, those with heart failure and chronic kidney disease, they predominate the SGLT2 inhibitor use as a first line after metformin and lifestyle modifications. Also, it reduces heart failure and chronic kidney disease progression. So, going to the essential part in my talk, the practical advice on SGLT2 inhibitors. The safety profile of SGLT2 inhibitors is well established. Very rarely we can see the genital infections and urinary tract infections in such groups, mild to moderate forms in severity. And it can be managed easily with some antibiotics, and no need to stop the medications unless it persists or becomes seriously. You can advise the patients to drink a lot of waters or plenty of waters, to clean the areas, the genital areas regularly. Also, there is some increased risk of hypoglycemia in cases of those patients who's using insulin or sulfonylureas. So we advise them also to reduce the doses of sulfonylureas or insulin to avoid the risk of hypoglycemia in such cases. Very rarely, in rare cases, some serious effects was found with the SGLT2 inhibitors use, like diabetic ketoacidosis, euglycemic diabetic ketoacidosis, very rarely. And it can be managed also simply by doing sick leave, sick day rules, and consider monitoring of urine blood ketones regularly for diabetic ketoacidosis. The patient needs to stop the SGLT2 inhibitors and should be admitted in ICU or in special care to treat the ketoacidosis until the patient is improved. Then we can restart the patients on the medications again. Some cases are very rarely noticed by the groups of canagliflozin or ertogliflozin, lower limb amputations, and it has some reported cases, which is also not so often seen. And we need to do annual foot examination, as mentioned by my previous colleagues, and foot inspection to avoid any early changes in vascular changes in the lower limbs. Very, very rare cases of foreigners gangrene have been reported in some cases of SGLT2 inhibitors use. And we know foreigners gangrene is necrosis or fasciitis in the perineal area, in the anal area, and around the genitalia. And it's very serious diseases, serious infection, and it should be stopped, discontinue the medications, and treat properly with the IV antibiotics and debridements. These are, in short, to review the very rare serious events. Coming to the dosing and administration guidance should be for the patient using the SGLT for the first time. We started as a small dose or up-titrated doses for the IMPA, 10 milligram, the DABA around 10 or 5 milligram, and canagliflozin 100 up to 300, ertogliflozin from 500, and we can up-titrate to 15 milligram. There are some contraindications for the SGLT2 inhibitors use. Patients with type 2 diabetes, type 1 diabetes, pregnant ladies, nursing patients lactating, patients below and younger age group, below 18, and those with low GFR. Even though now it's a new updated some studies, they start to use type 1 diabetes. Some cases they use the SGLT2 inhibitors. To remind the patients about taking the tablets, these tablets you can take it with or without food. You can swallow it with plenty of water. You have to be aware of the hydrations, and it should be the best thing, or preferably to take the dose before the first meal of the day. If the dose is missed, you can take it up to 12 hours before the next dose. Pay attention, as I said before, to the hygiene on the genital areas for avoiding the infection. Also, check up on the extremities for problems of circulation or wounds or sores. Kidney function should be considered when initiation SGLT2 inhibitors for us as physician. We have to do the creatinine clearance, the GFR considers for the empagliflozin and dapagliflozin and ertugliflozin. There is no need for dose adjustment if the GFR above 60. For the canagliflozin is up to 30 milliliters. You can use the SGLT2 inhibitors. Discontinue the medications if the GFR is dropped below 45 for the EMPA and DABA and the ERTO. So I think we can also advise the patients to avoid these some side effects to use. The SGLT2 has some impact on the patient who's using diuretics like thiazides and loop diuretics. It may add to the diuretic effects of such groups of medications and the risk of dehydrations and volume depletions and hypotension. So special attention should be given to volume intake, to encourage the patients to take a lot of fluids, a lot of water intakes. It was noticed that there are initial fall in GFR by the use of such group of SGLT2 inhibitors. Most of the groups, we can see initial drop of the GFR, but there is regain to the normal GFR level, especially in the empagliflozin groups or dapagliflozin. There is an initial dipping of the GFR with the subsequent stabilization of the kidney function. In periods of acute illnesses, all patients should be followed sick day rules to minimize the risk of complications. So you advise the patients to follow the hydrations. As I said, drink a lot of waters, to eat as normal, try to eat as normal, to monitor the blood sugar frequently, to avoid severe hyperglycemia. If they develop any symptoms or severe symptoms of severe thirst or polyuria, symptoms of diabetic ketoacidosis, conscious level disturbances, then you have to advise the patients to contact the nearest hospital or the nearest healthcare providers. Ketone bodies in the urine and should be also checked. Temperature to avoid any source of infection. So to seek advice for such patients if they are not sure what to do with these medications, if they have repeated vomiting, as I said, if they have severe hyperglycemia or symptoms of diabetic ketoacidosis. Some medications should be stopped in cases of sick day, then to avoid worsening of the conditions. Temporary withhold sulfonylureas or AC inhibitors, diuretics, metformin, ARBs, NSAID, and SGLT2 inhibitor is one of them. We should be stopped and hold until the patients improve the acute illnesses. Stepwise approach to prescription of SGLT2 inhibitors. We have to explain to the patients that candidate for initiation for the SGLT2 inhibitors Patients with type 2, they have high risk of atherosclerotic cardiovascular disease, high risk of heart failure or chronic kidney diseases, independent of the A1C nowadays, who's using metformin or without metformin. If they are on the targets or above the targets, you have to consider the SGLT2 inhibitors. These are the standard of care in 2020. Selection of the drugs, it depends on, as we said before, the GFR, we empagliflozin, we can start at 10 milligram, we can titrate it to 15, canagliflozin 100, and you can up titrate to 300, dapagliflozin 5 milligram, and then up to 10 milligram, ertugliflozin from 5 up to 15 milligram, either alone or to combine with metformin. Pre-initiation safety, as we mentioned before, the AGFR, estimated glomerular filtration rate is important for the EMPA and DABA, and ERTO should be above 60 milliliters. And for the CANA, can be used even above 30. SGLT2 inhibitors prescription, consider reducing the dose of diuretics if you are using the SGLT2 inhibitors in some cases. And you have to consider the genital hygiene, monitor the blood pressure for hypotension, food inspections for circulations, wounds, as we said, symptoms of DKA, and reducing alcohol consumptions. For long-term continuation of the drugs, also you have to monitor the kidney function for us as a primary physicians, weight, blood pressure, symptoms of severe hyperglycemia, dose up titration for glycemic control, and ensure adherence to medications. Coming to the end, I think addressing the systemic effect of type 2 diabetes should be a core objective of patients' management. Also, glucose control is traditionally the main focus of diabetic treatment, but nowadays, type 2 diabetes require a more holistic clinical management strategy to address the cardio, renal, metabolic challenges. So that means not only the blood sugar. The COFITs, the cardiovascular the cardiovascular output trials, evidence demonstrate the clinical benefits of SGLT2 inhibitors, and the new recommendation now strategy for the management of type 2 diabetes. Patient-centered care across discipline should be implemented using the evidence-based guidelines to improve patients' outcome, quality of life, and survival. The last slides, we have to weigh the benefits and risk of using this SGLT2 inhibitors group. The benefits we know of we know that nowadays that it will improve the glucose. Even with low hypoglycemic rates and attacks, it has impacts on the weight reductions, blood pressure reductions, uric acid decreases, reduce the risk of hospitalized heart failure. It reduces the risk of coronary vascular events and cardiovascular death. It improves the kidney outcome. The risk, of course, we have to weight it, genitourinary tract infection, the polyuria, the volume depletions, and ketoacidosis, which is very rare, bone fractures and lower limb amputations in canagliflozin groups. So after this, I think this is my end of the slide. Thank you very much.
Thank you, Dr. Bawahab, for this excellent review of the use of selective glucose transporter 2 inhibitors in the management of type 2 diabetes. Now we'll go to the last speakers today. Dr. Rashid Al-Juwairi is consultant endocrinologist and the head of endocrine and diabetes section at King Fahd Military and Medical Complex in Eastern Province. Welcome, Dr. Rashid, and he will talk about case presentation. Welcome, Dr. Rashid.
Thank you, Dr. Nasser. First of all, I would like to thank the audience for attending these lectures. And I would like to thank the Boehringer Company and the organization for invitation. So my lecture will be a case study, which is a clinical application on, depending on what presented by my colleagues since morning. So Muhammad is a 61 years old male who has diagnosed diabetes only recently for 1 year ago, and he's brought to the ER by his family with symptom of confusion and reduced level of consciousness. So you are the doctor in the ER, and he has hypertension also and benign prostatic enlargement. His current medication, he's on atorvastatin 40 milligram QD, ramipril 5 milligram BID, amlor 5 milligram QD, metoprolol 50 milligram BID, and glimepiride or Amaryl 4 milligram QD because he had got intolerance to metformin due to gastrointestinal irritation. So on examination, Glasgow Coma scale is 13 out of 15. Cardiovascular and respiratory examination are normal. Random blood sugars is 2.7 to documented with 48 milligram per deciliter, and blood pressure 145/82, and he's a little bit of obese with BMI 32. So you confirm the Weber trial, the hypoglycemic with documented and symptom, and he receiving IV glucose, which according to that, he regained his normal blood glucose and even regain his becoming conscious. So Muhammad is kept overnight for observation and discharged from the ER into the care of his family with advice to make follow-up appointment with his general practitioner. So before discharge, you did some investigations that showed hemoglobin A1C is 6.9, LDL is 1.6 or 69 milligram per deciliter, HDL is 1, triglyceride 1.4, total cholesterol 4.3, and GFR is 71 with urinary albumin creatinine ratio is 80 milligram per gram. So you informed Muhammad, doctor, about this result. So just think about this consideration. So if you were Muhammad doctors, what would you advise? So first, reduce dose of glimepiride. So this is not recommended because reducing the dose still he will not eliminate a risk of another hypoglycemic. In addition, will affect on his uncontrolled blood sugars in the futures. So second, switching to alternative glucose lowering medication could be because patients treated with glimepiride are at high risk of hypoglycemic event, and switching to alternative glucose lowering therapy is recommended as mentioned by our colleague this morning. Third, encourage weight loss with diet and exercise advice as recommendation of all guidelines. You know that the changing of lifestyle is the first recommendation for all guides in the world. Intensify antihypertensive therapy. Because of diabetes, increased Muhammad cardiovascular risk, so close monitoring and controlling of cardiovascular risk factor are crucial, and adding hydrochlorothiazide 25 or 12.5 milligram daily for additional control blood pressure. Add an additional lipid lowering agent. His will not recommended because LDL recommendation 70 and his LDL is 69. So just to remind you, this is explained a lot about my colleagues, but regarding if you're going to the 2020, just remind you that after the lifestyle, if the indication now, it is according to the specific of the patient, if it is has hypoglycemic or cost effective or obesity and heart failure or cardiac, you will do choose your anti-medical therapy according to that. If the patient is, this patient develop a lot of frequent hypoglycemia, so you have to avoid the drugs that causing maximum or a lot effect or side effect of hypoglycemia, and you will choose the drugs that causing less frequent of hypoglycemic, like the DDP4 inhibitor, GLP or SGLT2. So Muhammad, he's on compliance, he returned to you, but he didn't went to his general practitioner. So he came with the same concern, still he got hypoglycemic with feeling shaking and sweating, and his current medication is the same medication like before with no changing. Again, just remind you, atorvastatin 40, ramipril 5 mg BID, amlor 5 mg, metoprolol 50, and glimepiride 4 mg. So you examine him, blood pressure, still BMI 32, blood pressure is 149/84, and his still recent experience of sweating and shaking with usual occur when he has skipped a meal, and symptoms disappear after he eats a meal or snack, and this is called Whipple trial, with documented, of course, hypoglycemic before. So blood test results now, hemoglobin is 7.1, LDL is 1.9 with 74 milligram per deciliter, HDL is 1.1, triglyceride 1.4, total cholesterol 4.3, and GFR is 62 now, and with urinary albumin creatinine ratio is 267. So, back again to the questions. Kidney function looks normal given Muhammad age of 71 years old. So it is continue to monitoring kidney function more than or equal 2 times per year. Of course, it's not normal because according to the characteristic that the kidney function does not appear normal because there are 2 GFR measurements over time that indicated in 6 months period. We'll go with some evidence of kidney function decline. So continue to monitoring at follow-up appointment. Agree on that. Given that the majority of the drugs are excreted through the kidney, as you know, the decline of kidney function leading to reduced drug clearance and leading to accumulation and higher risk of side effects, and medication may therefore be contraindication in this way. So, or some of the medication need at least adjustment for this patient. Further kidney function decline is expected because of existing type 2 diabetes and refer to a nephrologist. Agree again, because patients with type 2 diabetes commonly experience a more rapid decline in the kidney function than those without diabetes, and kidney function decline increases at the risk of death, and particularly cardiovascular diseases, and appropriate control of cardiovascular risk factors and glucose are recommended. Again, what are you recommended for Muhammad management? You have increasing the dose of ramipril, initiation hydrochlorothiazide therapy, add an ARBs, repeat kidney function test, reduce the dose of glimepiride, stop glimepiride and initiate alternative glucose lowering therapy, add a second glucose agent. We'll go one by one. So the increasing the dose of ramipril, I think it would not benefit because this is in the higher dose of maximum taking according to the kidney function. Initiation of hydrochlorothiazide, again, is adding hydrochlorothiazide 12.5 to reduce the blood pressure to target 130/80 is acceptable. Adding an ARBs, there are a lot of study that dual RAS blockade with use of ACE inhibitor in the blood plus ARB is not recommended. Repeat kidney function test is repeat the kidney function test to assess the true loss of kidney function. Of course, stop glimepiride due to an increased risk of hypoglycemia. Now, this is the second attack and a severe attack. And you can choose one of alternative like SGLT2, that the SGLT2 inhibitor is recommended to reduce the risk of progression of kidney diseases, or you can use DDP4 inhibitor as a second line with effectively lower the hemoglobin A1C with low risk of hypoglycemic and has a neutral effect on weight. Linagliptin does not require dose adjustment with kidney declined kidney disease. So just remind you, this is the European, the same style after the lifestyle. You can choose your patient or characterize your patient according to the type 2 diabetes with NAF patient or in metformin, with atherosclerosis cardiovascular diseases or high or very high cardiovascular diseases. So you can add on SGLT2 or GLP-1 as monotherapy or add metformin. If negative, you can go for metformin and other medication. If it is on metformin, you can choose these drugs that has effective or on cardiovascular risk, and it is the SGLT2 or GLP-1 is the choices. If not responding, you can go for the others. So Muhammad, he's missed again the third one for his follow-up appointment, and we see him again in 6 months. So now why he came? Because of just new prescription of his medications. Don't just remind with that he got hypoglycemic sulfonylurea therapy. So now he's starting on empagliflozin 10 milligram daily plus hydrochlorothiazide, as we mentioned before. So blood pressure now is 145/82, and he has not had any further episode of hypoglycemic. Hemoglobin A1C is 7, but LDL becoming very rise with 3.7 was 143 milligram per deciliter with normal HDL and triglyceride. GFR, again, more decline with 49, and urinary albumin-creatinine ratio is 426. So Muhammad kidney function has declined further. So what are your immediate actions? Select all the apply. We'll try one by one. Replace hydrochlorothiazide with loop diuretic to further reduce the blood pressure. Yes, you have to stop it. The hydrochloride instead you can initiate the furosemide 40 milligram to control blood pressure and improve the urinary albumin-creatinine ratio. Referred Muhammad for all retinal examination on foot care consultation. Agree because Muhammad has now high risk of other microvascular complication due to existing vascular damage. Replace, switch to an Arab. Again, we mentioned that would not recommend switching Muhammad to an Arab because this will not improve his blood pressure. Increase the dose of Ramipril. He is on actually in full dose with 5 milligram BID, so it is not recommended increasing dose in Ramipril. Add Ezetrol to lower LDL. Agree on that. So there is some data showing that Ezetrol or ezetimibe plus the statin will reduce the LDL, but remember that it's very high now LDL. I don't think so they will, it is reducing by 10 to 15, but now it's very high with 3.7. So I think you can, we cannot recommend it. Maybe you can choose the BCSK9 drugs. Continue to prescribe IMBA to preserve kidney function. As mentioned, agree on that because he should stay on IMBA to preserve kidney function as the guidelines say and the data also. And kidney function has not meaningfully declined after the introduction of an SGLT2 inhibitor, although the urine albumin-creatinine ratio would be expected to decline with SGLT2 inhibitor, but high blood pressure may be a contributing factor. So what are your priorities for Muhammad long-term management? Maintain glucose control, preserving kidney function, screening for micro and macro complications, control blood pressure to target level less than or equal 130/80, address patient non-compliance and missed appointment, and all of that I think is true. It's just to continue the monitoring blood for glucose to controlling and regularly assess the GFR and urinary albumin-creatinine ratio more than or equal 3 measurements annually, and screening for micro and macro complications, especially including blood pressure and lipid, and reinforce advice around the diet, exercise, and smoking habit, very important, and regular screening for another vascular complications. Controlling the blood pressures to target level less or equal 130/80, and support patient attendance and compliance, patient family education, exploring reason for missed appointment. Don't forget this is 3 times missed, and disabling any anxiety may help. Just to remind you that empagliflozin significantly reduced the relative risk of incidence or worsening nephropathy by 39%. But just remind you again regarding the EMBA, a lot of questions. I found it this morning that the patient, you can use it easy if it is GFR more than 60, but if you got GFR less than 60, do not initiate the EMBA. And between the 45 and 60, you have to reduce the dose or adjust the dose. If it is less than 45, you have to discontinue EMBA. And this is again in the European documented this issue. And regarding that SGLT2, that the most countries, the GFR less than 45, except in Canada, where the GFR less than 45 only in DABA, but you can continue, discontinue the EMBA and canagliflozin if it is less than 30, and between 30 and 45, you can be adjusted. Also, somebody mentioned about the liver and the hepatic dosage adjustment. So no adjustment for the SGLT2 on the mild to moderate, not recommended, but there is no data sufficient regarding the severe impairment. And again, the EMBA, you can use it in the recent study. So what we get patient case learning point from Muhammad cases, that the diabetic kidney diseases attributed to diabetes occurring in 20 to 40% of patients with diabetes. Decreasing GFR and increasing albuminuria raises the risk of all causes and cardiovascular mortality, independent of other risk factors. In presence of hypertension and diabetes, declined kidney function is a very strong predictor for future vascular event. A kidney function decline, blood pressure increases, causing further vascular damage and progression of kidney disease. Optimized controlled glucose and other cardiovascular risk factors is recommended to reduce cardiovascular kidney events. SGLT2 inhibitor should be considered to reduce the risk of progression of the kidney in patients with a GFR more than 45. Optimal patient management required as a multidisciplinary approach, which may include primary care, endocrinologist, diabetes nurse, cardiologist, and podiatrist and dietitians. This is last slide, which is an summarize of between the SGLT2 and GLP-1 and DDP4 inhibitor, and you find the efficacy that the highest is GLP-1, hypoglycemic, none of them, weight, DDP4 is neutral, and the documentation of loss and GLP-1. Cardiovascular effect is proven in SGLT2 and in liraglutide, especially liraglutide, a neutral and DDP4 inhibitor, heart failure, benefit in Embacana and DABA. Oral, this is oral, subcu and oral, and in the progression of the kidney, this is the benefit, CANA and EMBA and DABA, benefit of liraglutide, neutral and DDP4 inhibitors, and dosing and contraindication, of course, taking care. Thank you so much, Dr. Nasser.
Thank you, Dr. Rashid, for this excellent case scenario and the practical about the management of a patient with type 2 diabetes and hypoglycemia. So now we'll open the stage for question. Please, if you have any question, submit it to the icon Q&A. So we invite Dr. Abdul Wahab, Dr. Rashid, Dr. Saeed. We invite you now to answer a question if there. If no, I will ask some question. So please, Dr. Abdul Wahab, what's your recommendation regarding the guidelines for the management or the use of selective glucose transporter in type 2 diabetes? So who are the appropriate candidates for these drugs?
These are very good questions nowadays, and so most of our colleagues should know this answer. Now, as we know, diabetic management is changing in the last 2 years. It's not controlling of blood sugar only alone. It is controlling of the risk factors of cardiovascular risk factors and per se, hypertension, hyperlipidemia, and the weight reductions. So starting the management of type 2 diabetes per se, I mean, we have to start on dividing the patients in 2 groups. non-cardiovascular risk factors or renal disease patients candidate, and those without any risk factors, younger age group, or those with normal kidney function, no cardiovascular risk factors, the patient non-smoker, not hypertensive, nothing. So we can use the standard therapy as it is in the protocol or the guidelines in the ADA and ESD, European 2020. Those with the risk factors, the atherosclerotic risk factors, or kidney diseases, or heart failure, then we start these new medications, the SGLT2 groups, especially the predominates on the renal and the heart failure. With atherosclerotic cardiovascular disease patients or risk patients, I think the GLP-1 agonists are predominates. If the contraindicated or not tolerated, we can shift them to the SGLT2 groups. Of course, in addition to the lifestyle modifications and to the metformin as a baseline.
Okay, thank you, Dr. Bawhab. Dr. Rashid, what do you think the health consequence of severe hypoglycemia if not treated properly? What can happen for the patient?
Yeah, of course. If he's not compliant or just he's missing, a lot of patients we face it in the clinic regarding this issue, especially the elderly and especially even the youngest, the youth. We have a problem with the hypoglycemic attacks. The newest style. The complication a lot of hypoglycemia affecting on the mentality, affecting on the loss of consciousness. Regain the consciousness, the psychosis or psychiatric regarding the family of the patient, or especially the young, if losing consciousness and taking care of him, or either elderly, their father, bring him to the ICU or bring him to the hospitals. If looking from our side, from the hospitals, a lot of money, a lot of cost regarding all of this stuff. So, and the further hypoglycemic less effect, showing this less mortality. There's a lot of studies showing the hypoglycemia, especially in NAS study, has more mortality, frequent mortality and morbidity than the patient with hyperglycemia even.
Okay, thank you very much, Dr. Rashid. So I found no question or unrelated probably. So, as in conclusion, really, the management of type 2 diabetes is not only related to the management of blood glucose only. We should look for other cardiovascular risk factors, and we should use drugs that are approved to decrease cardiovascular events in either patient with established cardiovascular disease or high-risk people. At the end of this, I thank all speakers. I thank all the audience, all the attendees to stay with us full for hour, rich of information about the use of selective glucose transporter 2 inhibitors in the management of type 2 diabetes. I want to thank Boehringer for sponsoring this event. I want to thank Saudi Heart Association and Kunuz Ritaj for their organization. Thank you very much. I think there is semi-hours for this events, and if you registered, will come for you. They will send Kunuz Ritaj for you the semi-hours. Thank you very much.